Sheila Manim, yeah. Seema ma'am, please go ahead.
Yes. So, Vardha, start, please. Hi, Sheila
A
ma'am.
very good, a
Hi,
very
hi,
good
hi,
afternoon.
everybody.
A very good afternoon to all of you. And it's my pleasure to welcome you all in this FOGSI ICOG certificate course on infertility in collaboration with ISAR. And yesterday we had a very engaging session on male infertility and ranging from semen preparation. And today also we expect a very engaging session, which shall comprise of infertility workup, hysteroscopy, and ART. And so I now hand over to Dr. Seema ma'am for further.
Good evening, everyone. And on behalf of ICOG Infertility Certificate course in collaboration with ISAR, my warm welcome is to Chairman Dr. Parag Biniwale and our guest of honors today, Vice Chairperson Dr. Ashok Kumar and Madam Chairperson-elect ICOG Dr. Sheila Mane. Welcome, sir, and welcome, ma'am. And I would like Dr. Ashok sir to give his words of wisdom for this master class.
Ma'am, sir, yet to join. Sheila ma'am will join.
Ma'am,
Yeah, good afternoon, everybody. And thank you, Dr. Seema, for inviting me and giving me this opportunity. And I think it is very nice to know that ICOG, under the leadership of Dr. Parag, you are conducting this certificate course on infertility for 3 days in association with ISAR. And yesterday, all the basics are covered, particularly in relation to male infertility. And today, it is a mixture of all the problems associated, like you have tubal, then how to assess the ovaries, and now we have the handy transvaginal ultrasound where it becomes easy to assess even the ovarian reserve, then the hysteroscopy, as well as we have all the stalwarts, like Madhuri Patil, Dr. Nalini Mahajan, and Sujata Kar talking to us on important like implantation failures and then non-responders and very important topics. As well as we have Dr. Damodar, Dr. Saket, and Dr. Narendra Malhotra, our senior past president, again enlightening the very important topics in infertility, and Dr. Seema and Shrutika to conduct the panel. And I'm sure that the delegates will be definitely benefited. And I really appreciate this certification course, because within such a short time, we are able to reach out to so many people and we are able to enrich them with so much of knowledge, and which will definitely help them in their practice, and automatically it helps the society in the long run. So I congratulate you and I wish all the best for this today's certification course webinar. And over to you, Dr. Seema. Once again, thank you.
thank you so much, ma'am, for your encouraging words. And once again, I would like to thank our chairman and our guests and all the faculty and delegates who are attending this course, infertility certificate course on day 2. And friends, infertility is all about the whole couple, and it's not, you cannot separate it. And in the lieu of that, we had divided the whole course in such a way that you can be familiar with all the parts which you are going to look at. So today's course is going to focus on female parts particularly, and we are talking about uterus, endometrium, tubal factor, and ovaries. And it's not only about how much eggs she has, how are her tubes, endometrium, whether it is receptive or was she suffering from some kind of infection. And overall, once when couple comes and tells you that doctor is saying everything is fine but we are not conceiving, and for that unexplained infertility, is it really an unexplained thing? We are going to focus on these topics and come with certain answers, which I hope that it will be of help, immense help to our delegates. With this, we'll start the session.
Thank you, ma'am.
And
We need to give some instructions to all our attendees because they should know that.
Regarding these.
Yeah. Varda, can you read that out?
Yeah, just want to share the instructions for all the participants about the test, the MCQ test. So attendance for all the 3 days course is compulsory, and the Google link for the MCQs will be sent in the chat box. Those who have attended in all 3 days course and passed with 50% marks are required for every day. And certificates will be sent within 1 month. And please note that this is an online certificate. So it is just an acknowledgement of attendance and depends on skill and experience. And of course, the course material details, you may communicate for the course details, you may communicate with the course coordinators.
Yeah, and we've done away with the pre-test. We've stopped having a pre-test. We'll be directly having a post-test at the end of the
Post-test, yeah.
right?
This is the change which we have done.
All right.
So, ma'am, may we start with the first session?
Yes, sure.
So we start with the first session, and for the first session, I take the honor to invite our chairpersons, Dr. Sao. She's a national coordinator, IAC Committee FOGSI, consultant gynecologist in Public Health and Family Welfare Department, MP Government. Welcome, ma'am. Dr. Priya Ganesh Kumar, she's chairperson, Gynecologic Oncology Society FOGSI, medical director, Sanivas Healthcare. Welcome, Dr. Priya, ma'am. Our third chairperson is Dr. Vinita Singh. She's Associate Professor, Department of Obs and Gynae, NMCH, Patna. She's also consultant, KARE Hospital and IVF Center. Welcome, Dr. Vinita, ma'am. The first speaker of the day is Dr. Damodar, sir. May I request the chairpersons to introduce the speaker? Or should I do it?
Dr.
Yeah.
Khan will.
Yeah, sure. Thank you so much for inviting me to chair this. Yes. So I would like to. Can you hear me?
Yes, we
Yes,
can.
ma'am.
Yes, ma'am, we can hear you. Please go ahead.
Dr. Damodar Rao and his qualification, as you can see, is consultant in OB-GYN, infertility laparoscopy at Rao Hospital. His diploma in gynae laparoscopy from University of Louisville, Kentucky, and his fellowship in laparoscopy at Beams, trained at Galaxy Care by Professor Shailesh Puntambekar, postdoctor fellowship in endocrinology course in 2012, and his medicine course in 2016. So organizational positions he has held till now. He's Tamil Nadu IAG Joint Secretary till 2022. You are FOGSI South Zone Organizing Secretary. And he is Tubal Organizing Society Treasurer since 19. And now awards and achievements. His Best Paper Award in Laparoscopic Suturing Techniques and Best Paper Award Hysteroscopy in Infertility. So I would like to invite Dr. Damodar Rao, please, for your topic.
Thank you, ma'am. Thank you for that kind introduction. Good evening, everybody. Let me just share my screen and pray that it opens. Sorry. Yeah, okay. Can you all see this?
Yeah.
Yes, but make it
Yeah.
full
You can
screen.
go full screen, sir.
Yeah. I've gone full
Better.
screen now.
Perfect. Yeah.
All right.
Perfect.
Thank you. Good evening, everybody. My topic is tubal factor evaluation in infertility. Would you do ART or surgery? So let's dive into the topic and see what evidence has to say. right? So tubal infertility contributes to about 25 to 35% of all causes for infertility. And what are the factors causing it? It could be due to pelvic inflammatory disease. It could be due to ectopic pregnancies, previous pelvic surgeries, endometriosis, and various other factors. How do you evaluate the tubes? Of course, HSG has been around for a while, considered the first line, but it's pretty crude, painful. And of course, it's an X-ray and exposing the patient into a contrast medium, which can be allergic at times. So SIS is also used, which is less painful, little more kinder to the patient, less radiation, of course. Only disadvantages, sometimes you cannot see the spill coming out in the distal end of the tube. And for this, HICOSI can be used, right? But the gold standard remains laparoscopy with chromoperturbation. And this will definitely tell you what the tubes look like. It's a see and treat in the same sitting. So what are the general considerations that you have to look into while when you have such a patient? You got to look into various factors when you have a patient with tubal pathology. You got to look into the male factor, age of the woman, presence of other infertility factors, ovarian reserve, history of prior fertility, number of children desired, site and extent of tubal disease, experience of the surgeon, risk of ectopic pregnancy, success rates of IVF, and patient preference. So you got to look into various factors before you decide on what you want to do for such a patient, right? So again, these factors can be divided into, you can have a proximal pathology, you can have also a distal pathology, or it can be all around due to pelvic adhesions. You can have, the tube can be affected in various parts of the tube. So let's look at proximal tubal pathologies, right? It's about 10 to 25%. Majority of them you will see when you see it in a HSG, it's usually due to a spasm, or you could be a mucus plug or debris, right? Other causes are, of course, PID, tuberculosis, SIN, endometriosis, and ectopic. So usually on an HSG, you might see that most of the time it's due to a tubal spasm, and just having a single finding of HSG is not sufficient to recommend surgery, right? You have to be able to differentiate, and this is usually seen only during a laparoscopy, or if the patient is willing to undergo another HSG, which usually isn't. The management depends on the status of the distal tube, associated adhesions, pelvic diseases. No intervention is required in a unilateral proximal tubal obstruction with no distal abnormalities, according to ASRM 2021. So selective salpingography and tubal cannulation is what is usually done. And I think the technique that is preferred by everybody world over, I think, is the hysteroscopic procedure. You do not want to use a fluoroscopic method because, again, you're exposing the patient to radiation. The best patient to do this on would be if she's young, no other associated factors, and normal distal tube. One of the methods that came across that could do away with laparoscopy is the HICOSI method, where you use foam in the contrast. Sorry, where foam is used in the contrast, and you can see the contrast coming out through the tube through an ultrasound evaluation. Excuse me. So there are a lot of papers about hysteroscopic tubal cannulation. Again, you got to remember there's only a proximal tubal cannulation, right? There are many people who just pass the guide wire and the catheter right through the tube. It'll even come out of the other end of the tube. That's to be avoided. It is not for that. It can be counteractive and cause further damage to the tube. It's only a proximal, the procedure is PTC, proximal tubal cannulation, right? So many papers that suggest that it's effective and safe form of treatment, and it's useful. Let's take you through a video here. So basically, we're just doing a proximal dye test, and you can see that there's no dye spill on both the tubes. The vision is not the best because we're using a 5 mm scope, right? So sorry about that. So if there's no spill on both the sides, we go by hysteroscopy. And there you can see that the ostia is sort of stenosed over there. And then the procedure is very, very simple, right? You just have to push in the catheter, you push in the guide wire first, and then you push the catheter over it, and then you can push the dye, and then you'll see good amount of dye spill. That is it. At the same setting, you can see if there is any other problem in the tube, any other problem with the ovaries. It's a see and treat kind of setting. Yeah. So what are the results with this? You usually see about 22 to 30% success rate, but there is a small chance of an ectopic pregnancy of 4%. So, and if she does not conceive in about 6 to 12 months, then you'll have to look at other methods in which she could conceive. The other proximal tubal pathology which can be corrected is through, you could be corrected through a tubocorneal anastomosis. Again, it depends on absence of male factor, age of the woman, status of the distal tube, and the quality of the technique. In any of these anastomosis, the quality of the technique is very, very important. And of course, patient selection, right? Advantages, it maintains the integrity of the cornea, maintains the length of the tube. So there are various techniques that are involved. I'm not going to get into the details of the techniques. I have a video of this, which I'll be showing you later on. It's very similar. Basically, you have to freshen the edges and take the 6 o'clock stitch first, and then the rest will follow, right? What are the success rates when you do this procedure? For tubocorneal anastomosis, you have a pregnancy rate of about 55%, live birth rates of 33 to 56%, and ectopic pregnancy of 10%. What is the ASRM committee opinion on proximal tube pathologies? What they say is, if the proximal blockage on HSG is clearly due to SIN, selective salpingography or tubal cannulation can be attempted, right? If it is not due to SIN, confirm normal distal tubal anatomy always. IVF is preferred to resection and microsurgical anastomosis, right? So what they actually prefer is just your proximal tubal cannulation. If that can be attempted, then go ahead and do it. But they're not in favor of doing a microsurgical tubal anastomosis because the results are probably not the best compared to an IVF. So distal tubal pathologies, what are they? They could be due to sterilization procedure. They could be to hydrosalpinges. You can have femoral phimosis. You can have peritubal adhesions also. Again, the surgeries for this are tubal anastomosis. And then you have your salpingo-ovariolysis, a fimbrioplasty, and salpingostomy. Again, amongst all these, what I attempted nowadays is, of course, your salpingo-ovariolysis, where you're just doing a little bit of release of adhesions, or a tubal anastomosis is something that is also commonly done. The other procedures like a fimbrioplasty and a salpingostomy is not really done. You either would do a tubal clipping or a salpingectomy instead. So tubal recanalization, if you look at India, the female sterilizations in India are about 37% amongst women aged 15 to 49. And for this population, better success rates after surgery than patients with tubal pathology. So what they're saying is you get better success rates after a sterilization procedure. But again, nowadays, the whole debate is about how you're doing the sterilization procedure, right? If you're just applying rings, then you get the best success rate. But if you're doing a coagulation and cutting the ends, or if you're doing a fimbrectomy, there's no good results you're going to get. So how the sterilization done was also very, very important. So factors affecting outcome: age less than 30 years has good outcome, 88% success, and the site, isthmic, is better. Surgical technique that was used for sterilization, that's what I was talking about, whether you use rings or clips versus ligation, resection, and coagulation. Duration between sterilization and recanalization procedure. And of course, the tube length, it should not be less than 5 centimeters. Okay. Worst case scenario, 4 centimeters. That's what you should mainly look out for. Ampulo-infundibular segment of 3 centimeters and isthmic segment of 2 centimeters. We generally look at the whole length of the tube, and if it is more than 4 centimeters, we probably go ahead and do it. So what are the results with this procedure? Pool pregnancy rates are about 65 to 68%. The rate of ectopic pregnancy is 4 to 8% versus IVF is only 1.4%. So early surveillance when the occurrence of a positive pregnancy test in these cases. If no pregnancy occurs within 6 months, an assessment of tubal patency is suggested. ASRM supports the recommendation for microsurgical anastomosis for tubal ligation reversal. So ASRM supports this procedure. There are various articles that have come out. One is which supports tubal recanalization. This is JMIG 11,000 procedures. Again, it has been supported, and it says that patients has a benefit of over IVF in younger patients and well-selected patients. That is very, very important. And they also say that because the procedure is being, done less nowadays because of the advancement of ART, reproductive surgeons are not well trained in it. So they should also get trained in it to give patients better results. This is a small video of mine. Basically use vasopressin to reduce the bleeding. I prefer scissors to sort of freshen the edges. I'll just run through it quickly. And patency is checked of both the ends. And once patency is checked of both the ends, we use a hysteroscopic guide wire to sort of give stability to the tube while suturing. So the guide wire is passed in, and there you can see that how the tube becomes taut. And then basically you take sutures, you take the 6 o'clock stitch first, followed by the 9, 12, and 3 o'clock ones. And most of the times you'll see that with laparoscopy, it's become very nice because magnification is really good, especially with 3D nowadays. It's becoming really nice to operate on these patients and give better results. All right. Salpingo ovarian lysis, again, this has been done, and you have pregnancy rate of 51 to 62%. Fimbrioplasty and salpingoneostomy has also been tried. Again, the success rates vary anywhere between 40 to 13%. Hydrosalpinx, again, if you come across this, whether you're going to do a salpingostomy or a salpingectomy followed by an IVF. Most of the times, I think you do a tubal clipping or a salpingectomy followed by IVF. Salpingostomy alone nowadays is not really done. So what's the evidence finally say in the end, whether you're going to do surgery or ART? Advantages of IVF over ART are good per cycle success rate, 28 to 30%, 31.2% live birth rate per cycle. It is less invasive. Disadvantages are, of course, your cost, frequent injections, risk of OHSS, and higher incidence of adverse perinatal outcomes. That's debatable. Reconstructive tubal surgery, of course, it's a one-time procedure, attempt conception every month and may conceive more than once, inexpensive, overall low risk. Of course, you have it's a surgery and you have complications related to surgery, increased risk of ectopic pregnancy, lower success in IVF, and need for good expertise, right? So I'll just have 2 more slides. So candidates for tubal surgery are young with no other significant fertility factors and tubal anatomy that can be repaired. Only alternative for women with tubal factor infertility who are unable to undergo ART. So this also you should keep in mind. Success rates are 30 to 60% and dependent on the skill and patient selection. So if you look at both, ART success rate is high in severe tubal disease. Surgery is variable. Invasiveness is less in ART. Time to conception is quick if IVF works. Cost is high. Risk of ectopic is also low. IVF over surgery, if in proximal tubal, if the obstruction is not overcome by tubal cannulation in older women and significant male factor. IVF over surgery in distal tubal obstruction, again, salpingostomy followed by IVF improves the success rate. So which is better? Results of tubal surgery and IVF are not directly comparable because surgical success is reported as pregnancy rate per patient, whereas IVF success rates are per cycle. And let's probably end it by saying they're complementary and not competitive. The significant improvement of results with ART offers the reproductive surgeon of today the luxury of operating on cases with a more favorable prognosis, which results in improved success rates for a given procedure. Tubal reconstructive surgery and ART must be considered complementary forms of treatment for women with tubal factor infertility. So take-home message would be careful patient selection after thorough investigation, selection of the most appropriate surgical procedure. Age remains the most important prognostic marker. Prefer IVF in older women, male factor infertility, and multiple factors. Thank you.
Thank you, Dr. Damodar. Very pertinent topic. Very easily explained, basics clear, and that video of yours was self-explanatory.
Thank you,
Thank
ma'am.
Yes. Now over to next topic now. Dr. Priya is there, I think. Chair.
As the chairperson to introduce our second speaker, Dr. Sanket Desai, who shall be speaking on hysteroscopy, your third eye, diagnosing and treating simultaneously.
In meanwhile, I would like to request Dr. Damodar, excellent talk. Please keep answering the questions of delegates in chat box only.
Yeah,
Okay?
yeah, sure. Thank you so much.
Hi, Sanket.
Hello, madam.
Hi, Sanket.
Hi, Damodar.
No, Sanket. Dr. Priya, I saw. Will you introduce? Or I do it, Bebo?
I can introduce.
So many to.
Dr. Sanket Pisat is a well-known endoscopic surgeon from the city of Mumbai. He's been trained in several international centers, including Belgium and Italy, and he's attached to multiple hospitals in Mumbai. Until recently, he was a member of the Mumbai OBGYN Society. He's also served as an executive member of IEG, and he's well known for his innovations in endoscopic surgery, including the Sanket Pisat's needle. He's one of our young firebrand leaders as far as endoscopic surgery is concerned, and I wish him all the very best for his talk. Over to you, sir.
Thank you, Dr.
Perfect.
Pratik. Thank you, Seema madam, for this opportunity and for the lovely introduction. So, the topic given to me today is hysteroscopy, your third eye. What I'm going to try to do is present a brief overview of hysteroscopy and try to understand what to do, what not to do. More importantly, when to operate, but I think a little bit more important, when not to operate. So let's begin the presentation. The entire presentation has series of running videos. So at any time, if you feel that the video is not playing properly, please do interrupt me so that I can recheck at my end and reshare. So let us start with the presentation. When it comes to hysteroscopic surgeries, I'm sure more of you, there is some background noise, please.
Shreya, please check the.
Yeah. So as far as hysteroscopy is concerned, we all know that hysteroscopy has changed the course of the way that we practice infertility and fertility enhancing surgeries. And without hysteroscopy, there would be so many lesions that could never have been tackled and managed, giving rise to very good reproductive outcomes. So, commonest cases which we see in the OPD are usually not fraught with the decision of how to operate, because even if you are someone who is not doing surgeries on a daily basis, you can always operate as a team. But the decision of whether to operate or whether not to operate is the decision to be taken by the fertility specialist or the primary caregiver himself or herself. And in that line, you know that we have many pathologies that can come up during when the patient comes to us. Let's start with the most basic of the pathologies. Let us first start off with endometrial polyps. So the question to be answered is, do all polyps need removal? Will they regress? And which polyps actually cause infertility? So in one simple line, if I had to answer that, any polyp which is approximately 1 centimeter in size or more requires hysteroscopic removal before the patient attempts fertility. What about polyps that are lesser than 1 centimeter in size? Well, these polyps can to some extent go away on their own. However, with a very small polyp, there is some possibility that this will happen. But as the size of the polyp increases, mostly a polyp is a lesion which will require surgery in order for fertility enhancement to be successful. In this table, you see that the size of the polyp is not really related to the pregnancy rate after its removal. So it does not mean that if the polyp is 5 millimeters in size, there will be less fertility enhancement after its removal as compared to something which is 1 or 2 centimeters in size. So the bottom line is, if you find a polyp during stimulation or during the course of management of the patient, a space occupying lesion of the like a polyp has to go before the patient attempts fertility. Once you have found a polyp, then exactly what do you do with it? Most of the times, removal is by hysteroscopic scissors. For smaller polyps, they can simply be cut off from the base. And for larger polyps, what we can do is something which is called as a slicing technique. This technique enables us to cut the polyp into smaller bits, and then these smaller pieces are extracted one by one. What is important to remember is that when this is being done, the polyp has to be cut right from the base. So try to not leave any part of the polyp behind. Often people who are doing the surgery in the earlier part of their learning curve hurriedly attempt to take out whatever they can of the polyp, leaving majority of the polyp behind, and that is what actually leads to recurrence in most cases. So try to take out the complete polyp right from the base, and you will be surprised at the extremely low recurrence rate that you get, regardless of whether you use a hysteroscopic scissors or whether you use a resectoscope for this purpose. For larger polyps, a resectoscope can also be used. So the point is, if it is a very small polyp in an unmarried girl, you can definitely leave it alone and there is some possibility of regression. But as the size of the polyp increases and in patients of infertility, removal of polyp will definitely help. Now we come to the second pathology, which is septate uterus. And in septate uterus, the dilemma faced by most gynecologists is to decide whether the patient who presents with a report like this requires surgery or not, or in other words, to ensure how can we be sure that this is not a bicornuate uterus but a septate uterus. Simply put, the answer lies entirely in doing an MRI, and this is the Conuta classification, which stands for Congenital Uterine Anomalies Classification. This is given by the ESHRE, and this has classified septate uterus as a class U2. So what we need to know, it looks like a septum, but is there a septum? And if yes, does it require surgery or not? Very simply put, the definition of septum as per Conuta classification: on the coronal section of 3D ultrasound, draw the interosteal line, draw the line below the interosteal line up till the maximum depression of the septum, and draw a line above at the same point. If the green arrow is more than half of the yellow arrow, then this is the patient who requires surgery. This moves away from the centimeter wise classification which is being given by the ASRM, which is also followed sometimes, where they define septate uterus as an inward indentation of more than 1 centimeter. But this one seems to be more reliable because it relies on the patient's own uterine myometry. So, an internal indentation at the midline not exceeding 50% of uterine wall thickness can be considered as a normal uterus, and we avoid the use of absolute numbers. What about bicornuate uterus? Simplest strategy is to look at the external fundal contour. So, in this uterus, you can see that one would easily mistake image number 3 for a bicornuate uterus. But if you look at the green arrow and the external fundal indentation, you find that this is smooth as compared to picture number 4, where there is a depression in the midline. And this suggests that 4 is a bicornuate uterus and 3 is a septate uterus. So that's the easiest way of differentiating between a bicornuate and a septate uterus. Does a septum resection improve pregnancy rates and reproductive outcome? Well, this is more or less a controversy, so we don't really know. However, most studies are still very much not in agreement of what should be done. As fertility specialists and as endoscopic surgeons, generally we tend to believe that if you see a septum and if it falls within the criteria of septum that have been described up till now, one should go ahead and cut the septum. So, what you should not cut, on the other hand, is a slight fundal indentation not confirmed by USG. And a large indentation, you must always remember that it also could be a bicornuate uterus. So one must confirm by doing a 3D USG or by a concomitant laparoscopy. Incidentally, if you find some indentation on hysteroscopy, there is no point in dealing with that indentation and causing more harm than good in the first place. So this is the septum being incised. There is nothing to excise in most septa. It gets absorbed into the uterine wall, and you can see the uterine volume which has significantly increased. Post surgery, if you give them estrogens, most of the times the endometrium comes and covers this entire layer, and fertility rates after such kind of surgeries are usually very good. Then we come to longer septa and more vascular septa, where we usually prefer to switch over to resectoscopes because these septa can really bleed sometimes. And with a resectoscope, you get the ease of cutting it fast, but one has to be careful about perforation. And one also has to worry about not using too much energy so as to damage the endometrium and leave intrauterine synechia as a sequelae of your surgery. So cut from one half of the uterine cavity to the other half, and as one reaches the fundus, one has to be little more careful so as to not cause any injury to the fundus of the uterus. So that's it more or less about septum resection. And then we come to the most controversial part, which is the lateral metroplasty. So in lateral metroplasty, previously we've had debates over whom should be subjected to metroplasty and whom should not. But the CUME classification now does away with this controversy, and they have defined three specific criteria: the lateral angle, the lateral depth, and the cornual angle. And only if these all three criteria are satisfied is a uterus which needs to undergo lateral metroplasty for the sake of fertility enhancement. You can diagnose this on two-dimensional ultrasound also by thinning of the endometrium in the lower two-third of the cavity, something referred to loosely as rat tailing of the endometrium. At the end point of surgery, one must be able to have a spacious triangular cavity and both walls that where you are able to see both the ostia in a single straight line from the vantage point of the internal os. So, does surgery for T-shaped uterus improve reproductive outcome? There are many controversies, but it is now well known that if you do your case selection properly, most definitely this surgery is very rewarding and results in good postoperative outcome in most cases. To sum up, T-shaped uterus do not operate on a slight lateral indentation not confirmed by a 3D, and do not operate just because incidentally on the hysteroscopy you feel that there is a little bit indentation. You may end up doing more harm than good. Also, the infantile uterus and young recently married women, they deserve a trial before you subject them to surgery, because you never know, in spite of the low uterine volume, patients still might conceive and you might get a good reproductive outcome. So that's the lateral metroplasty. We usually prefer to perform lateral metroplasty using hysteroscopic scissors. And with hysteroscopic scissors, you see that we are able to get a good area of the cavity or a good enlargement of the cavity. So we already discussed this. Now let's move on to submucous fibroids. So the question is, do all submucous myomas require surgery? And the short answer is yes. If there is a fibroid compressing on the endometrial cavity, then definitely the fibroid has to be removed. And nowadays, bipolar resection has almost entirely replaced monopolar electrosurgery. So we all use bipolar resectoscope loops in order to remove the myoma. The question that comes to mind is, in which cases is laparoscopy indicated? Because this is something that most gynecologists are still not clear with. And can a submucous myoma require a laparoscopic removal? So when we go back to our FIGO grading of fibroids, one finds that in the FIGO grading of fibroids, there is a specific category mentioned type 2 to 5. Now, in this category, type 2 to 5 is a fibroid which is a transmural fibroid, meaning that it has an endometrial presence. It also has a presence where it is bulging the serosal margin. In such a case, attempting to remove this fibroid from below can be catastrophic and very, very troublesome, because you will find that the patient will have quickly go into a lot of fluid overload and something like this. So you have this fibroid, you are tempted to remove it by hysteroscopy, but your preoperative imaging suggests otherwise. You can see on laparoscopy also, I am not able to visualize the fibroid at all. So removal by hysteroscopy seems like the correct option, but on good preoperative imaging, it has been shown that the fibroid is almost completely intramural with a very small submucous component. So you can see the thin layer of myometrium which is there over the fibroid. We go inside, put in a myoma screw, remove the fibroid, and we remove it by laparoscopy. What is the advantage here? Though you have done laparoscopy, look at the size of the fibroid. Attempting to remove this fibroid from below would have definitely pushed the patient into fluid overload, and most definitely would have caused so much of endometrial trauma that the patient would not have been able to conceive in the future. On the other hand, here you have given her a laparoscopy scar and a uterine scar, but the patient will conceive with minimal damage to the endometrium at the end of the day. The most difficult of all, I think that's all we have time for, is intrauterine synechia. These can present as bands and lateral walls, also being convergent. Hysteroscopy is definitely indicated in these cases. You have to go in with the hysteroscope, remove all possible manner of synechial bands, and then put patient on some kind of adhesion barrier, and also, if required, perform a second look hysteroscopy. So you can see there are various grades of synechia that we have over here. All of these have to be cut. Once this is done, what you need to do is, I'm going to end in the next few seconds. We usually put in a pediatric Foley's catheter as an adhesion barrier. This serves to keep the walls of the uterus apart after surgery and prevents re-synechia formation. So we leave this inside usually for a period of 2 to 3 to 4 days, and we find that a balloon or a triangular heart-shaped balloon like this goes a long way in preventing re-synechia formation. So I think that's all that we have time for. I thank you all for your patience and for listening.
Thank you, Dr. Sanket Kiswat, for covering so many important concepts for like a mini crash course in applied endoscopic surgery, hysteroscopic surgery. Thank you very much for a wonderful talk, brilliant videos, and there are some questions in the chat box requesting you to please address them in the chat box itself. We will move on
All
to the
right.
next speaker, please.
All right. Thank you.
Thank you, sir.
Dr. Varda.
Is Dr. Vinita Singh there? Requesting you to please introduce Dr. Narendra Malhotra, sir. If not, Dr. Varda, you can go ahead.
Vinita Singh ma'am is yet to join.
So third speaker of the day is Dr. Narendra Malhotra, sir. He needs no introduction. He is the Managing Director, Global Rainbow Healthcare Hospital, and he shall be talking on evaluating the ovary in infertile couples. Welcome, Dr. Narendra, sir.
Yeah, hello. Very good evening to all of you. It's indeed a pleasure to be here in this ICOG course once again, and we'll try to share how we can evaluate the ovary for infertile patients. And let me just get back to my slides. So yeah, can you see my slides?
Yes.
Yes.
So evaluating the ovary in infertility, especially the ovarian reserve evaluation, is what is very important, and that's what we're going to concentrate more on. And of course, the pathologies. So the objectives of this lecture would be how to understand what is the role of the ovary in fertility, learn the methods on how to evaluate the ovarian reserve and ovarian function, review some of the imaging and hormonal assessment and their correlations, and of course, try to look at a few of the ovarian pathologies. We all know that infertility affects about 10 to 15% of couples worldwide, and ovarian factor contributes to 30 to 40% of female infertility. Evaluation of ovarian function is very, very crucial in diagnosis and treatment of planning. I would say that tubal, ovarian, male functions, these are the three functions which should be evaluated first at all, and then the rest 10% of the functions or the problems can be evaluated later at all, if all this is normal. So what does the ovary do? What does the ovary do? Now, ovary produces follicles, that is folliculogenesis, and causes ovulation and a release of an oocyte, mature to oocyte, which is a central process of a natural conception. And then this ovary produces some hormones, and these hormones are estrogen in the follicular phase, progesterone in the luteal phase, AMH and inhibin. Regular cycles, if the patient is having regular menstrual cycles, then we are assured that the ovarian function is normal. So that is your first in the history to note whether the ovarian function is normal or not normal. And that's what we can do by taking a good history of the menstrual cycle. So let's see what happens. Now you have these primordial follicles, which a woman is born with, and then they become activated primordial follicles, then they become primary follicles, and then they become secondary follicles. And these will become atretic and secrete a little bit of estrogen. Now, this happens in a girl right from till she achieves puberty. And whatever estrogen is released from here has her development of breast and the body shape and the skin and the others. Now, this portion of intra-ovarian regulation is IGF-1 and androgens and AMH. And then you have the extra ovarian regulation, that is the follicle stimulating hormone and the luteal hormone. And this part is the gonadotrophin dependent follicular phase. And finally, these primordial follicles go like this, and they'll become atretic. One of them becomes dominant, the rest becomes atretic and ovulates, and the cycle goes on and on. So when you look at them in this graphic form, the AMH is here. Then there is a control of the follicular pool by the genes or the genetic aspects, and the primordial to the activation of the primordial growth. And the follicle stimulating hormone receptors develop with the AMH, and this follicle stimulating hormone will be responsible for the estradiol and for the folliculogenesis. So these, as we know, that ovaries also age, or what we call as the reproductive aging. Now, fertility is reduced with the increasing age in women because the number of follicles are going to get reduced. There is a biphasic decline. That means a loss of follicle accelerates around 37 and precedes menopause by 10 to 12 years. In India, we've seen in the various studies that this decline starts at 35 or a little bit earlier, because Indian women have a menopause, average age of menopause lesser than our Western counterpart. The whole thing, when studied about the genetics, or what was called as the genome-wide association studies, to see how ovaries age, how DNA repair genes are impaired in early menopause, and how many genes relate to antioxidant defenses and tumor suppressions. And all this is altered by the epigenetics of where we are living in, what we are breathing, what we are eating, the plastics, the endocrine disruptors, all that. Now, female fertility decreases in function, in quality and quantity both. That is what we see. See how the decline is from performance percentage 100 to 50, like that. And that leads to subfertility, sterility, onset of irregularity, and menopause. And the follicular pool decreases. And the count goes down repeatedly, like here, this green line. And finally, this hormones decrease. So what we have is what we call as the ovarian reserve. A diminished ovarian reserve is more common occurrence as more women postpone childbirth due to modern society, due to social demographic trends. Diminished ovarian reserve is one of the primary reasons for a poor ovarian outcome. And Vicky se baat kar lo, uske phone aa raha hai baar baar. Proper prediction of ovarian reserve before initiation of the treatment can decrease cycle cancellation. And this helps the clinician to establish alternative treatment option. That means whether the patient has to go for oocyte pooling, for ovarian PRP, for ovarian stem cells, or how we can go ahead to do oocyte donation. So all this will depend on your ovarian reserve and how to do it. So it becomes very important for us to understand ovarian reserve and get it right. Now, another thing to remember is that the quality of the egg is governed by age, because there is no nuclear DNA damage. The quantity of the ovarian follicles in the ovary are determined by AMH and AFSA, because there is constant active recruitment. So a younger woman with a lesser AMH and a lesser antral follicle count has a better chance of having a successful pregnancy. An older woman whose AMH is yet normal, but because of age, nuclear DNA damage has occurred, she has a poorer chance of getting pregnant. So it is age, not the ovarian reserve, which predicts pregnancy. That is point number one. A younger woman less than 35 with a lower AFC and AMH has a better chance to get pregnant than an older woman more than 35 with a normal reserve. So ovarian reserve is not the only criteria for success in infertility treatment, especially ART. Now, what happens in ART? In ART, we stimulate the ovaries and do an artificial insemination or a IVF or an ICSI. And we aim for IUI, we aim for 2 to 3 mature follicles. For IVF, we aim for 7 to 8 follicles. So you have in vitro fertilization, ovarian stimulation, aim to get multiple mature follicles with the ovarian stimulation. So that. Now the concerns here for an ART specialist is that the ART response may be poor. And the response is poor, there will be cycle cancellation, poor pregnancy rate, or the response is excessive. So that means the risk of ovarian hyperstimulation or a very high E2 levels, which is detrimental to implantation and outcome. Hence, it becomes paramount important to assess the ovarian reserve accurately. Now, how do we do it? The assessment can be done by AMH, by antral follicle count or AFC, by other means which are formulas like FOI, follicle to oocyte index, that is a oocyte number per antral follicle count into 100, or AMH and FSH to oocyte ratio, that means AMH divided by oocytes, AMHO, or FSH divided by oocyte, FSHO, FSH oblique O. Or FORT we call it as the ratio of pre-ovulatory follicles, 16 to 20 millimeters into 100, divided by the small antral follicles which we are seeing, which have not grown. Or OSI, that is the ovarian sensitivity index, where the total FSH dose is divided by the number of retrieved follicles. Plus the other tests like ovarian blood flow, ovarian volume, other surrogate markers, and the other tests. Now, this is how the FOI is. Now, you see the FOI here is normal. That means more than 50%. That means there were so many follicles identified and you got so many eggs, more than 50%. Whether there was a high pool or a medium pool or a low pool. If you're getting more than 50% of the eggs you see, that means it is normal FOI, follicle oocyte index. A low FOI is when you get less. You see a big pool, but you get very few eggs. You see a 4 pool and you get only 1 egg. So that is the low FOI. So what are the tests which we can do or to a patient who comes to us? Well, with the ultrasound, you can do an ovarian volume, an antral follicle count, which all of us should be very well versed in, an ovarian stromal vascularity, which is also very easy, the hormonal markers of AMH, FSH, and inhibin, and some advanced ovarian assessment by 3D volumetry, automatic antral follicle count, serum biomarkers like AMH, inhibin, combined B panels, genetic testing where there is premature ovarian insufficiency, and artificial intelligence for ovarian image analysis. What are the hormonal assays? We used to be taught of doing an FSH-LH on day 2, and if it was higher than 10, it suggested poor ovarian reserve. Estradiol could be very low in ovarian failures or could be on the higher side in the follicular phase. That means the follicle has started being recruited in the previous cycle. So premature recruitment of a follicle, which will shorten the cycle, would also a problem. And you'll get a E2 of more than 80. AMH reflects the antral follicle count very accurately. Inhibin lower level suggests that there is a diminished ovarian reserve. AMH is important. AMH is important because it is stable throughout the cycle. AMH less than 1 is associated with poor ovarian response to stimulation. A high AMH of more than 4.5 is seen usually in polycystic ovarian disease. So a low AMH, a low AFC, a low AMH, and a low ovarian reserve. And that is how we say that if it is less than 0.6, it is low. If it is 0.7 to 2.9, it is normal. If it is more than 3, it is high reserve. If it is more than 5, it is PCOS-like, or more than 4.5. So how do we evaluate? Well, gold standard is the transvaginal ultrasound. And when you do a scan and focus on the ovaries and count the follicles which are there, that's the antral. So we count the follicles which are 2 to 10 millimeters. The bigger than that are not counted. So these small follicles, as you see in this brown image, 1, 2, 3, 4, 5, 6, 7, 8. We'll leave the bigger one, 9. So one side 9, 1, 2, 3, 4, 5, 9 plus 5, 14. So it's normal. Here there are very many, and this is a high reserve ovary. A count of less than 5 suggests a poor reserve, and a count of more than 15 suggests a high reserve or a high responder or a PCOS. And then the volume 3 to 15, 3 to 12 could be in normal. Less than 3 is low reserve. More than 12 is a high reserve ovary. So pelvic ultrasound is the most important scan to be done, or most important test to be done, which will tell you the antral follicle count, which will tell you the ovarian volume. And if you put the blood flow on, you see the ovarian artery comes and enters to the hilus, and then it breaks into spiral coils. And when the follicle grows, the spiral coils get straightened up and more blood flows. So if you have more stromal blood flow, more FSH will reach there and you will get hyperstimulation. So ovarian stromal blood flow predicts whether the hello.
Hello.
Hello, can you hear me?
Yes, sir.
Yes, yes, sir.
Oh,
Yes, sir, we can hear you.
because here it is showing that I've got cut off.
I can't see you, but you are audible.
Yeah, we cannot see you.
Video is
It's
not there.
not moving.
Please rejoin. वर्धर सर को दोबारा से ज्वाइन कराओ.
हाँ.
Talks and questions which are not answered, we can discuss that.
We can take up the questions in the chat box.
Does ovarian PRP increase the stromal blood flow? Is one question. So, anyone interested in taking this question? PRP is full of growth factors as it is coming from the blood, and platelet-rich plasma is its name. So theoretically, it should be doing something like in improving the blood flow or giving more growth factors for angiogenesis and things. That is the theoretical basis, but evidence is not too much that it can be recommended routinely for that function.
There's another question here. When to cancel the cycle? The blood stroma is less than 3/4, 1080. May we proceed with the second session?
I think he was almost at the end of his talk.
Yeah.
Yeah, okay. Let's do that.
Okay.
Shreya,
Must be
please
some
make the
genuine problem.
co-host to Narendra sir.
Narendra sir से बात
Yeah,
होगा
sir.
आप
Back.
Yeah,
Narendra sir
join,
is here.
Aage.
Sorry,
He's back.
I didn't know what went wrong.
Okay.
So you're back.
Thank you, sir. You back?
Yeah, I'm back.
He's joined again. Okay, that's great.
Yes.
I'm back. Can you see the slides now? Yeah.
Yes, sir. Yes, sir. We can see.
So we're talking about ultrasound, ovarian volume, antral follicle count, and the stromal flow. Counting AFC is very easy if you do it correctly. If you cannot, then you can resort to 3D, and the 3D will tell you in all the calculate the volume for you. So it does the both the thing.
Tarannu?
There
Aaya
is,
Meena?
Please,
there is,
Anu, mute yourself.
there is a tendency to have an inter-observer variability. I might count 7 and someone may count 8 or 9. And that could be there. So pooled, you can do a pooled one, and then the variability is seen to be about 1.6 to 2, so not too much. So pooled SD for intercycle variation, if it was 15 counted, it could be ranging into 2 to 3 problem. Remember, AFC is not affected by any stimulation. So clomiphene citrate and downregulation will, because you're counting it here and you're not counting it in the gonadotrophin dependent phase. If there are too many, then we use the automatic Sono ABC. And the Sono ABC is a very, very good method for coloring each size of the follicle and calculating the volume. It does not give the size. Or you have this niche mode where you can cut through the ovary, walk through the ovary like this. Then it is very important for us in a dominant follicle to see the cumulus and its vascularity all around, like we can do. So a cumulus can be seen in about 60% in 2D, in 3D, and with color, the perifollicular blood flow. And it is said that the perifollicular blood flow, though people harp on it, is not so that significant. If there are too many, then we use the 3D and the 4D for PCOD, and we use the Sono ABC to calculate it. What does age do to it? Now, with every year passing, the follicle AFC decreases by about 0.3 or 0.5. So you get a loss of follicle of about 1 every 2 years. And it decreases 60% from the age of 22 to 42. So what the AFC in a girl was at 22, it will be 60% less at the 42. And of course, the decline is 0.35 follicles per year. How about volume? Now, when you're using the 3D, you get all the 3 planes and you can count the AFC and you can also get the volume at the same time. So now this is 3 to 12, but less than 3, then it is a poor volume. How does AMH or AFC correlate with the other? AFC and AMH results, AMH is a lab test, will take time. AFC is immediate. You're doing it yourself. With AFC, there could be an inter-observer variability. With AMH, if it is done properly, no variability, but the lab standard has to be there, and a good correlation with AFC, with the number of oocyte obtained in IVF cycle. And similar with AMH. So they both are quite similar, but the advantage is if you're doing it yourself, do the AFC. Stromal blood flow, I just said, if there is a lot of stromal blood flow here with a good diastolic blood flow, as you can see here, that means a lot of FSH is going to reach the ovary and stimulate the ovary. So it is a pointer for a hyper responder, and that is where it could help. Poor ovarian blood flow will tell you poor responder. Perifollicular blood flow by 2D, by 3D can be seen, but it is said that the ovarian stromal blood flow and perifollicular blood flow are of no value. But you see, at least the 3/4 of the follicle should have blood. Similarly, the endometrium has blood. So there should be a very good ovarian endometrial correlation on the endometrial receptivity. That means the layers, the thickness, and a dominant follicle. And this would probably tell you that everything is going good. We can use this in IUI, we can use and protect it. So that is all about the reserve. Now, a couple of slides. I cannot go into the detail of all the pathologies, but what you should be looking at on being careful of on a day 2 ovarian scan, whether the ovary is polycystic, enlarged, whether there are endometriomas, and if there are endometriomas, whether you have a normal ovarian tissue around it or not, what is the size of the endometrioma, whether they're bilateral, whether you push and pull and you see whether there is deep infiltrating endometriosis or what, whether there are simple cysts, ovarian tumors, dermoids, or whether there is a premature ovarian insufficiency. These pathologies are the main one which we have to look at. And very simple to see: a corpus luteum cyst, a 3D cyst, an endometrioma, a luteal cyst with color blood flow. And this is a cyst, simple cyst, which was occurring before stimulation. So we can put in a needle and drain it and start your stimulation that day. This could be done. And if it is If you want to treat them, you can also inject escarole. Maybe I think I have a video of that which I'll show you. So 2D, 3D, Doppler, MRI is not needed and only needed in special. PCO is very important and PCO should be diagnosed correctly. So you can have the inversion mode or you follow the criteria of NIH or Rotterdam or AAS or the modified latest ASHRAE, ASRM criteria for PCOS, which is now 15 to 20. Now in PCOS, it could be poor responder or it could be a high responder, and that color Doppler will tell. So controlled ovarian stimulation will depend on age, the basal FSH, the AMH, and the antral follicle count, and that will make you decide these 4 parameters, how you should stimulate that ovary and what dose you should be there. Of course, it can be amended by the BMI. So what are the problems? Ovarian stimulation, PCOS could be hyper-responder. Could be a stagnation of follicular growth, plateau, that is not increased. Could be no response, or could be a poor ovarian response or a poor responder, and then maybe thinking of dual stimulation or dual stim. Endometriosis, we are not very sure how endometriosis affects or whether endometriosis is more or fertility is endometriosis. But we are very sure that whenever there is endometriosis, there's going to be abnormal follicular genesis, anovulation, abnormal luteal phase, there'll be immunological factors, there'll be endometrial dysfunction, there'll be mechanical factors, and that will all lead to infertility. So the distorted pelvic anatomy can be seen by ultrasound, altered peritoneal function by push and pull, altered hormonal and mediated, all that has to be studied, and all that the endometrioma has been caused. And then, of course, we will classify these women on the revised classification, or what we call as the RAFS classification, where you can predict which endometriomas with a score of 6 will have a higher chance of pregnancy, and with a score of David Adamson's classification that you can do. What are the indications of doing IVF in endometriosis? Well, grade 3, grade 4, tubal block, associated male factors, and severe adhesions, or what we have done, adhesolysis. IVF pregnancy rates are going to be lower in women with endometriosis than those with the tubal factors, and especially with bad endometriosis, that we have to see. Whether we're going to drain the cyst before or not depends on how much normal ovarian tissue is there. If you have a normal tissue around the ovarian endometrioma, please do aspirations, do follicle pooling, and take out all follicles in 2 or 3 stimulation cycles, and then do the surgery, and then do the frozen embryo. And that's what the ASHRAE guidelines on endometriosis state. Now, surgery is reversed for big ones and for where the pelvic anatomy is. When there is dermoids, the other things, you could have huge dermoids, and that need to be treated before we are going to. And as I showed you or told you that we can do cyst aspiration by normal TVS. Here's the cyst. You can aspirate the cyst, and we have made escarole solution, which is and then you can inject the escarole into the cyst so the recurrence does not occur. So that is a way which we can handle if there are big cysts when you have the infertility patient. So, ladies and gentlemen, the factors affecting ovarian stimulation are age, BMI, ethnicity, smoke. In other factors, FSH, LH, receptor polymerism, past performances, and drug tolerance. And poor ovarian response has to be kept in mind and diagnosed very well. And there are the biomarkers for ovarian response, as we showed you, are what AFC, AMH, and that would be your treatment strategy if it is low or high. If it's a high response, antagonist control agonist trigger, or antagonist control HCG trigger. If it is normal response, long down regulation, agonist control. If it's a reduced response, flare agonist. If it is negligible response, try flare agonist, or switch over to oocyte donation, or switch over to, or try stem cell injections in the ovaries and ovarian rejuvenation. So according to Poseidon group 1, 2, 3, 4, we will do a Poseidon classification for poor responders, and that is where it will help you to decide how to go about. So to conclude, AMH, AFC, clomiphene challenge test, GnRH, agonist stimulation test are the 4 tests which we are doing. And we'll correlate them clinically with the all other pathologies which you have. So evaluation. The key takeaway points are that ovarian evaluation is very crucial. AMH and AFC are the most two important tests. Regular monitoring will improve the ART outcomes. Early detection of reduced reserve will allow you timely intervention, whether it's pooling, whether it's fertility preservation, whether it's PRP or stem cell injections or whatever. Early detection of any ovarian pathology will make you deal. So first day scan is very, very important to counsel the patient whether she has a normal ovary, an abnormal ovary which needs surgery, or she has a high response or a low response or whatever. So to conclude, ovarian assessment should be your first line of evaluating female fertility. And of course, tubal evaluation and the male factor. These three factors should be evaluated on day when the patient comes. And for this, day 2 scan is essential, or an early follicular phase scan, and pathologies, if needed, should be treated before women are subjected to any stimulation or any ART. So with those few words, I thank you very much for inviting me here. And I've tried to bring out some of the points, practical points, and the points for the ICOG candidates where they can do the theory part of the exams. Thank you for inviting me.
Thank you, sir. Thank you so much. As we are already running short of time, we quickly move to the second session.
Yes.
And may I take
we'll move to the second session, Dr. Varda. So
Yeah,
it was a
may I-
fantastic session. So for the next session, I would like to invite the chairpersons for the next session. Can we have their CV? Dr. Alok Sharma. Yes. Dr. Alok Sharma, he is founder secretary of Indian Menopausal Society, Shimla chapter, and he has been founder secretary of Indian Fertility Society, Himachal Pradesh chapter. Welcome, Dr. Alok. Our next chairperson is Dr. Vidya Thobi. She is vice president elect FOGSI 2025, and she is president KSOGA 2023 and chairperson Food, Drugs and Medical Surgical Equipment Committee, FOGSI. And she has won Best Committee FOGSI Award, Dr. Mehru Dara Hansotia in 2020. Welcome, Dr. Vidya. Our next chairperson is Dr. Vandana Bansal. She has done her first postdoctoral fellow of National Board in India, qualified in high-risk pregnancy and perinatology. And she has 28 years of experience in OBS and gynae, including 23 years in fetal medicine. Welcome, Dr. Vandana Bansal. So over to you, chairpersons, to invite eminent speakers. Yeah, chairpersons.
You can go ahead and introduce them.
Okay, I'll invite. It's an honor to
Hello.
introduce Dr. Madhuri Patil, madam. We all know her, but it's,
Hello. I joined, but I was not unable to make unmute. I could not unmute myself. Okay.
Yeah, Dr.
Very
Vidya,
much
please,
for
please
those
go.
kind words. You can continue.
Yeah,
please.
I'll better start my talk so that
Yeah.
rather than
Yes, madam. Yes, madam. We all know you.
Professor
So,
Thobi,
Better
welcome.
you should listen to Madhuri. Yes.
Yeah. So if you stop sharing, I'll share my slides. So today I'm going to talk on management of poor responders depending on the Poseidon group, whether they improve the results. So we know that a successful endpoint of any ART treatment is live birth rate, and this depends on the various factors, including adequate number of follicles being stimulated, adequate number of oocytes being retrieved, the quality of the oocytes, and this in turn will depend upon the ovarian response. And the ovarian response depends upon the controlled ovarian stimulation protocols that have been given. All of us are aware that we require a certain number of oocytes because they positively correlate with the live birth rate. And this study by Sunkar et al. Has shown that maximum live birth rate is seen when we have more than 15 oocytes which have been aspirated. And if you have lesser than that, that is associated with decrease in the live birth rate. So I'll straight away go to the patient stratification according to the ovarian response, where we can divide the patients into poor response, where we have 1 to 3 oocytes, suboptimal response where we have 4 to 9 oocytes, normal when it's 10 to 15, and hyper when there are more than 15 oocytes. And the prevalence of suboptimal response is most important because here the ovarian reserve is normal, but yet we have lesser number of oocytes that have been retrieved, and the prevalence of suboptimal response is about 43%. And as you can clearly see over here, that at any given age, a lesser number of oocytes is associated with lower live birth rates. So coming to the Poseidon classification, where it's classified into 4. Group 1 and 2 have similar features, that is the antral follicular count is more than 5, AMH is more than 1.2, and this is again further divided into 1A and 1B. In 1A, you have less than 4 oocytes retrieved. In 1B, you have 4 to 9 oocytes retrieved. And the only difference is that the younger one, the group 1, the woman is less than 35 years and the older is more than 35 years. So basically, this is a group where you have good ovarian reserve, but unexpected, less number of follicles or poor response. Whereas group 3 and 4 are associated with low ovarian reserve, and we have already heard Naren's lecture where we know what is low ovarian reserve. And group 3, basically, they are less than 35 years, and here basically it's quantity which is an issue, whereas group 4, the age is more than 34 years, and it is not only the quantity but also the quality an issue. And this 2 groups, basically, we expect them to have a low ovarian response. So usually in all these 4 groups, it's few embryos that are generated, and also it is associated with reduced cumulative live birth rates. So if you look at the cause, 3 and 4, it's very easy. We know it's related to low ovarian reserve, and group 4 probably it's also related to age. But group 1 and 2 basically are hyper-responders with normal ovarian reserve and show a suboptimal or unexpected poor response to exogenous FSH. They are associated with hyposensitivity to FSH, and therefore the ovarian response, though is normal, they tend to show an increase in the cumulative FSH dose and in the stimulation length, as well as they are associated with low FOT. And it may be related to a single nucleotide polymorphism, either in the FSH or LH receptors, exposure to environmental toxins, oxidative stress, and excessive free radical. It could be related to low gonadotrophin starting dose, asynchronous development of follicles, and there could be issues with the trigger as well as the oocyte pickup. And if you look at the reproductive outcome in these groups, we can see that the number of oocytes retrieved is significantly less in 3 and 4. The clinical pregnancy rate as well as the live birth rate is also significantly lower in Poseidon 3 and 4 in all the studies that have been published. But one must remember that it's not only the quantity, but also the quality that is important. And basically, the measure of success is the number of oocytes required to obtain 1 euploid blastocyst. So if the age is less than 35, you require 6 cumulus complexes and 5 M2 oocytes to get 2 blastocysts to get 1 euploid blastocyst, and the euploidy rate is 60%. Between 39 to 40 years, you require 10 cumulus complexes, 8 M2 oocytes, 3 blastocysts with a euploidy rate of 30%. Whereas if the age is more than 40, you require 16 cumulus complexes, 13 M2 oocytes, 5 blastocysts with a euploidy rate of 20%. So we can see that the younger Poseidon groups, that is 1 and 3, have a higher euploidy rate than the older groups, that is Poseidon group 2 and 4. There's also a correlation of the live birth rate and the number of oocytes retrieved in Poseidon 3 and 4. And if you divide these patients into 3 groups, the patients who have an AMH between 0.52 to 1.19 are associated with increase in the number of embryos that are available for embryo transfer, and this is statistically significant. So let us see what is the management of these low prognosis patients. So the first step is to identify the low prognosis patients and stratify according to the Poseidon classification. Then you need to calculate how many oocytes we need to obtain at least one euploid embryo. And it's important for us to increase the follicular synchronization, increase the receptivity to FSH of the follicles. Then we need to plan for our treatment. We have to individualize the control ovarian stimulation strategy to achieve the estimated number of oocytes. And basically in Poseidon 1 and 2, we have to optimize the ovarian response, whereas in 3 and 4, we have to maximize the ovarian response. And the step 4 is counseling, set patient expectations and discuss the therapeutic alternatives that are available to them. So the most important is FORT and FOI, and which Narendra has discussed, and therefore I will just omit these slides. And the most important is to calculate how many oocytes are required. So pre-treatment basically depends upon the female age, the sperm source, and and then we calculate the success probability, and then that tells us how many mature oocytes are required. But we can also calculate post-treatment if she's undergone a previous cycle where we basically also take into consideration the number of mature oocytes that have been obtained in the last cycle, along with female age, as well as the sperm source, and then that will give us the success probability and how many oocytes are necessary. Coming to the various treatment strategies according to the Poseidon criteria, we have to look at the type of gonadotrophin that has to be given, whether addition of LH activity helps, and whether there is any success which increases with increase in the starting dose. We have to choose between the agonist and the antagonist. We have to choose between various stimulation protocols like the conventional stimulation, mild stimulation, natural cycle, and dual stimulation. We have to see whether accumulation of oocytes and embryos is necessary. We have to look at the trigger strategies, wherein we have to choose between HCG, double or dual trigger. Adjuvants can be given like DHEA, testosterone, growth hormone, and CoQ. Retreatment with estrogen and OCPs for 8 to 10 days is an option. Embryo transfer strategies, whether we want to go for fresh, if there is no risk of OHSS, or frozen if PGTA or dual stimulation has been done. Luteal phase strategies basically should be identified. Progesterone is the best drug, but in those who have lesser number of follicles, HCG may be given because it also has a positive effect on the implantation rates. And one has to also use personalized lab techniques. So the basis of management is to improve the FORT, and this can be done by higher doses of FSH or adding LH, or improve the FOI by synchronization of the follicular cohort with pretreatment, decrease duration of stimulation, and also using dual trigger, which may have advantages. And this will help us in increasing the responsiveness, recruitability, as well as growth of the follicles. Now let us look at the evidence for evidence, and first we will deal with stimulation strategies. And this meta-analysis published in March 25 has said that lower number of they compared low versus high gonadotrophins, and they concluded that lower number of oocytes are retrieved with mild stimulation protocols, and this was statistically significant. But you can see that there is no difference in the clinical, ongoing, as well as live birth rate. They also looked at the delayed start protocol, where ovarian stimulation was started 7 days after GnRH antagonist. And what they found is that there is a significant improvement in the number of oocytes retrieved as number of mature oocytes, which was statistically significant. But there was, again, no difference, as you can see here, in the clinical pregnancy rate, live birth rate, and miscarriage rate. Coming to LH, there are several papers that have been published, but I've just taken the recent ones. And what they said that the number of oocytes retrieved were more in the REC-FSH group in Poseidon 1 and 2, but advanced maternal age with normal or suboptimal ovarian response benefit from treatment with combined REC-FSH and REC-LH in the ratio of 2:1. And this resulted in increased number of oocytes retrieved, increased implantation, as well as clinical pregnancy rates. Coming to dual stimulation, basically all these studies concluded that there is increase in the total number of oocytes, M2 oocytes and embryos compared to single stimulation. Rate of patients obtaining at least one euploid blastocyst is also increased. There is shortest time to obtain an euploid blastocyst. And this was a paper which I really felt was good, where they did a dual stimulation. But the first one they did in the luteal phase, and the second one they did in the follicular phase, and therefore these patients underwent a fresh transfer. But with dual stimulation, there's always an increased risk of wastage of oocytes and embryos. Coming to the triggering strategies, there was a non-significant increase in the live birth rates with dual trigger from 8% to 28%. The mean number of COCs and M2 oocytes were significantly higher when HCG was given for trigger as compared to agonist given, and this was statistically significant. And the number of excellent and good quality embryos on day 3 were also significantly higher when HCG was used for triggering. And therefore, probably a dual trigger may be beneficial because GnRH agonist results in a surge of both FSH as well as HS, whereas HCG basically increases only the LH. We also need to look at the usefulness of oocyte accumulation in low ovarian response patients. And this was a study of 188 patients who underwent PGTA with oocyte vitrification. And they compared patients who had accumulated oocytes at embryos and one stimulation cycle. And accumulation, basically, they did when they had less than 10 M2 oocytes. And I think this is a very big number, especially in our Indian population. And after PGTA, basically, they transferred a euploid embryo. So when all these, two stimulation cycles, 3 stimulation cycles were compared, what they found was that AMH and antifollicular count number of oocytes retrieved per pickup and total number of biopsied embryos were significantly higher when in the 2 stimulation cycle group as compared even to 3 stimulation cycle group. And after chromosomal analysis, about 18.5% of the biopsied embryos were euploid and 58.9% patient reached embryo transfer. There was no difference in the pregnancy rates per patient between 1 stimulation cycle, 2 stimulation cycle, and 3 stimulation cycle groups. As you can see over here, that there were 36.8, 34.9, and 31% respectively per embryo transfer or even per embryo transfer. And in patients with less than 10 M2 oocytes after COS, undergoing PGT, accumulating oocytes can render a pregnancy rate per patient and per embryo transfer comparable to those of fresh cycle. Coming to the adjuvant treatments, this meta-analysis and RCT published in March 25 looked at DHEA, and what they found that though there was increase in the number of oocytes with DHEA, the number of M2 oocytes as well as the clinical pregnancy rate, live birth rate, and miscarriage rate were almost similar in both the groups. But with testosterone supplementation, there was an increase in the number of oocytes retrieved, clinical pregnancy rate, as well as live birth rate. But there was no difference seen in the number of M2 oocytes, as you can see over here, as well as the miscarriage rates. Coming to other adjuvant treatments, again, when letrozole and clomiphene was used along with gonadotropins, there was no difference in the number of oocytes retrieved, metaphase 2 oocytes, clinical as well as live birth rate and miscarriage rates. With growth hormone, we know that there are contradictory studies. Some studies have shown higher number of M2 oocytes, but no effect on the clinical pregnancy rate and ongoing pregnancy rate, whereas others have shown higher number of oocytes along with increase in the clinical pregnancy rate as well as ongoing pregnancy rate. And this study, latest study published in 21, showed that there was improvement in the clinical pregnancy rate as well as live birth rate for low prognosis women diagnosed with Poseidon criteria who failed a previous IVF cycle. So this was a criteria in the study. Coming to estradiol or OCPP treatment, estradiol, it improved the follicular synchronization in the antagonist cycle, but despite that, there was no difference in the number of oocytes retrieved, M2 oocytes, as well as clinical pregnancy rate. and OCP pre-treatment prior to COS in this study, it was concluded that it was a favorable approach than waiting for a natural menses in Poseidon group 1. We all know that mitochondria is a very important structure in the oocyte, and its abnormality is closely linked to the low prognostic outcome in IVF, and therefore supplementing the functional mitochondrial content or improving the mitochondrial function by autologous mitochondrial transfer or mitochondrial related regulating drugs may improve the clinical outcome in this group of patients. And you can see over here that all the 4 groups, that is group 1, 2, 3, and 4, do have problems with their mitochondria. So these 2 studies looked at using coenzyme Q10, and what they concluded was that in young poor responder women with decreased ovarian reserve, pre-treatment with CoQ10 enhances oocyte and embryo quality and increases the ovarian response to stimulation. There is a possible beneficial effect on the clinical pregnancy rate and live birth rate, but this needs to be confirmed in large RCTs. Further research is needed to determine the best course of therapy, timing, and dosage, and to assess the therapeutic impact of CoQ10 supplementation in the poor ovarian response patients with poor prognosis. Coming to intra-ovarian platelet-rich plasma, the number of oocytes obtained during successive egg retrieval exhibited a consistent increase, probably because of the mechanical influence, but it did not lead to a higher percentage of euploid processes or improved pregnancy rate. As you can see that the p-value was not significant. Then the study in 2022 looked at the follicular activation, where ovarian fragmentation for follicular activation was done, and this resulted in increase in antifollicular count, but did not modify the IVF outcome when compared to the controls. Coming to the various laboratory techniques, the number and quality of embryo generated from the limited number of oocytes retrieved from low responders are important aspects of infertility treatment, and there is lack of data regarding the role of follicular size, specifically in low responder patients. Use of dual trigger seems to be good strategy in low responders. Use of artificial oocyte activation with calcium ionophore may improve fertilization, embryonic development, and outcome in these patients. And data on blastocyst transfer are conflicting, and no high-quality studies have evaluated whether the live birth rate is higher after blastocyst transfer than after cleavage transfer. Specific evidence for PGTA in low responder patients is also lacking. PGTA should be considered in Poseidon group 2, especially if the woman is more than 38 years, because you have enough oocytes and therefore you can subject these patients. But if you go to do PGTA in group 3 or 4B, where you hardly have any embryos, then probably PGTA may result in no embryo transfer. Therefore, a decision to use PGTA in poor responder patients with low number of oocytes need to be made in consultation with couples undergoing ERT, taking into account the potential outcome of each decision. 86.3% of poor ovarian response patients who had 4 oocytes retrieved and underwent PGTA did not obtain a euploid blastocyst for transfer. So let us just look at treatment in each groups. So in Poseidon group 1, you have to look at the ART calculator and genotype screening, and possibly a pharmacogenic approach may be done. One could use either agonist or antagonist protocol. REC FSH is preferred over HMG. We could increase the dose by 50 to 75 if there's no polymorphism, and in the presence of polymorphism by 75 to 100, and probably adding LH really is useful in this group. Dual and double trigger improves the FOI, and fresh transfer is preferable, and elective freeze-all with segmentation if there is risk of OHS or PGT is planned, and a single blastocyst transfer should be done. In Poseidon group 2 also, the treatment is almost similar, but here consider adding LH in the dose of 150 IU right from day 1, and dual stimulation also is an option, whereas there's no difference in the trigger and transfer strategies as compared to Poseidon group 1. Coming to Poseidon 3, adjuvant treatment may be given. And if not planned, we can start stimulation, either agonist or antagonist. Rec-FSH should be given in a dose of 300 IU. And LH should be added if there's follicular stagnation. And dual stimulation is an option. Dual or double trigger will improve the FOI. And if low FOI, then basically next cycle you could consider adjuvant treatment, change timing of retrieval, and go for dual or double trigger. In Poseidon
Sorry to
4,
interrupt you, ma'am.
yes, I'm just finishing. This is the last two
Oh,
slides.
okay, ma'am.
So duals, so here again, you have to use a combination of Rec-FSH and LH, and Rec-FSH in the dose of 300 and LH in 150. Dual stimulation is an option, or one could go for new stimulation if an agonist protocol is used, triggering again with dual or double. And basically, one could go either for a fresh or a frozen embryo transfer. I'll just omit. So I conclude saying that the Poseidon classification allows for individualized management of poor responders in ART, considering both age and ovarian reserve. Management should be tailored to each patient, focusing on maximizing oocyte yield by setting realistic expectations. Adjuvant therapies and novel stimulation protocols are promising, but require further evidence for widespread adoption. Low quality is not low quantity. This is very important to remember. And this heterogeneity is primarily determined by the woman's age, reflecting the importance of oocyte quality. The low responder is not always poor, the old ones are, and the clinical live birth rates vary between all the Poseidon groups, and therefore a personalized approach to COS tailored to individual characteristics of patients will ensure a patient-centered and evidence-based approach that should optimize fertility outcomes. So basically, we have to remember that there is light at the end of the tunnel, with newer modalities of treatment being investigated with larger RCTs, and these patients who are low responders should not be sent or should be advised oocyte donation right away. Thank you.
I think Dr. Madhuri, it was an excellent talk, and I think it was very informative as well. You covered almost all the poor responders as per the classification, the pre-treatment and all those things. I request you please answer the whatever questions are asked in the chat box because of the paucity of time. Thank you very much.
So chairpersons kindly invite our second speaker, Dr. Nalini Mahajan.
Yeah, can I have her CV, please? Dr. Nalini Mahajan. Yeah. So it is a pleasure for me to introduce Dr. Nalini Mahajan. I'm not seeing her CV as such, but she's talking on chronic endometriosis, diagnosis and management. And she's a director of Mother and Child Hospital, founder, president, Fertility Preservation Society, India. So over to Dr. Nalini Mahajan.
I just want to check, are my slides visible?
Yeah, your slides are visible,
Right,
and
okay.
make it slideshow.
Yeah, I will. I just wanted to make sure that. Okay.
Please make it slideshow.
So, good evening, everybody. Sorry?
Ma'am, it is endometritis.
Chronic
Yeah, it is
endometritis,
she has written
diagnosis
chronic
and management.
endometriosis, but the topic given was chronic endometritis.
Sorry, I'm so sorry. I think it was a, I think it was a printing a mistake because I just cut.
So you are talking on endometritis, right?
Endometritis, sorry, yeah. I'm talking on endometritis and not endometriosis. What is the diagnosis and management, is it different from genital TB? So before I begin, I want to thank Dr. Seema and all of you for the kind invitation. And let's move on as there is paucity of time and I have a next session right away after this. So we know at a fundamental level, if something is wrong with the uterus, pregnancy, conception is not going to happen. So that is the first point which we have to correct. There are many reasons for uterine factor infertility, but today what we are dealing with is endometritis, and that too the chronic endometritis. Now, for long we have only considered genital tuberculosis as chronic endometritis, but today we also recognize an entity which is non-tubercular chronic endometritis, and we're just going to look at that aspect as well. So tuberculosis, I don't need to tell everybody, it's by Mycobacterium tuberculosis. The primary infection is in the lung, and thereafter generally the body contains the infection, and many years later you can have infection get spreading into the extrapulmonary sites as well. Now there is the activation of the tuberculosis bacterium depends on how much immune control there is within the body. The more the immunity, the more the containment of infection. As soon as the immunity starts going down, the infection starts, getting activated. And one of the most common causes for reactivation of MTB is immunocompromise and malnutrition, chronic illnesses like diabetes, surgical manipulation, high steroid levels, use of immunosuppressant drugs, and incomplete or inadequate antitubercular treatment. And if you look at our infertility group, you can see what is, we are doing all of this, which will have higher chances of conversion of a dormant tuberculosis to overt disease in our patients. Now, in tuberculosis, genital tuberculosis, the first target is the fallopian tubes, and initially there is endosalpingeal damage. So from the outside, the tube looks perfectly fine, and we treat it more like unexplained infertility. In case the exosalpinx is affected, then there's beading and cornual block, and it becomes a little more obvious because the healing is by fibrosis. Again, in the uterus, which is the second target, initially you may observe nothing itself except for alteration in endometrial receptivity, a thinning of the endometrium, and decreased blood flow. When the disease progresses, you have ulcers and synechia, and by that time really there is not much that you can do in terms of reversal, because again I'm repeating, the healing is by fibrosis over here, and once that happens, it is very difficult to reverse and get the basal layer of the endometrium going again. Now the new thing, or the one which is coming into prominence now, is that the ovaries are also affected by tuberculosis, which is dormant or which is not at least overtly active. And in this, some of the early signs are an LUF, a decrease in ovarian reserve, decrease in the perifollicular blood flow, and of course in the later stages you are going to have the routine TO masses. And of course cervix, vagina, vulva is a little rare, it's not so common. Now, endometrial receptivity, what happens at the level before we have any damage, structural damage to the endometrium, is that the anti-inflammatory cytokine expression increases. So you have upregulation of the pro-inflammatory cytokines and downregulation of the of factors which allow for implantation. And that is what happens, and that is why one of the things we see is a recurrent implantation failure. Now, what are the tests that we use for TB? We know that it's a paucibacillary disease, so we need a battery of tests to actually diagnose, and sometimes even that is not enough, and we have to treat on the basis of clinical suspicion. But that is what we can use are imaging techniques like ultrasound and HSG to look at the tubes. Laparoscopy, hysteroscopy is a very good aid to tell us what's happening in the pelvis. And then specific tests, which are AFB stain, culture methods, the molecular tests like NAT and Gene Expert Ultra. Now, these are some of the tests which are, we do, but unfortunately, because the endometrium has, the bacteria are so few within the endometrium, the bacilli, sorry. So it's very difficult to culture. Even in the NAT test, sometimes we don't get it. And that is why we need a combination of tests to diagnose and treat these women. But when you treat them, the treatment has to be complete 6 months. Do not do incomplete treatment, because then they may land up into multi-drug resistant tuberculosis and we are in further trouble. Now, coming on to what is the, the symptoms, basically it's mainly asymptomatic, and the patient may come to you with infertility, primary, secondary, adverse pregnancy events, or menstrual disorders. These are the two of the commonest. And, then of course you have the systemic stuff, etc. But look at what happens in the reproduction. In the reproduction, if there's tubal involvement only, the pregnancy rates, of course, patient comes as unexplained infertility, IUIs don't work, and in IVF, the pregnancy rates in the early stages before the endometrium is involved may be okay. But as soon as the endometrium is involved, because the receptivity is altered, patient is going to have repeated failures. So that is why there's an urgent need to really test accurately and treat early tuberculosis before the damage is done. Now, what about chronic endometritis? What is the etiology? It is infective mainly, and it's an ascending infection from the vagina. Especially when we are doing surgical procedures, we may, introduce the vagina into the, bacteria into the vagina, and thereby then they will move on into the uterus. So very, very important to, do a very good cleaning, thorough cleaning of the vagina when we are doing vaginal procedures. The organisms involved are E. faecalis, E. coli, Enterobacteria, Klebsiella, Gardnerella, Mycoplasma. So a plethora of organisms which are actually sometimes very difficult to identify, and, because they are within the uterus, and from uterine aspirates, it is very difficult to grow these organisms. Again, clinically silent or paucisymptomatic, therefore becomes a diagnostic challenge. Patient may present with infertility or AUB or menstrual dysfunction, maybe dyspareunia or a little bit of discharge. And it is relevant to us because of the infertility, because of miscarriages, because of ART failures. Now, chronic endometritis is defined as a persistent localized inflammation of the endometrial mucosa. And at a histopathological level, what you find is mucosal edema, increased stromal cell density, dissociated maturation of the stroma and epithelium, and presence of plasma cell infiltrates and lymphocytes in the stroma. So initially, the inflammation is going to involve the endometrium, but it can move to the endocervix or into the salpingeal mucosa. So again, how much the infection is and what is can the uterine environment, microenvironment control that determines the degree of damage that will happen to the endometrium. Now again, diagnosis here is a bit of a challenge. A diagnostic hysteroscopy can show you micropolyps, stromal edema, a strawberry appearance, which is hyperemia basically. So this can point you that, okay, here this is looking inflamed and there may be a problem here. Ultrasound is not of much use. So ultimately you have to do a biopsy where you can send it for histology and culture, but immunohistochemistry and examination for plasma cells is the basic gold standard of diagnosis here. So when should you take the biopsy? If you take it during the proliferative phase, or you may take it at LH+7, you will have the maximum possibility of finding the plasma cells. The tissue is collected in formalin, and the plasma cells are identified by either hematoxylin eosin staining or by IHC for Syndican-1. And this is the commonly used one. CD138 is, we check for these cells. And if you're doing hematoxylin eosin, you'll see this clock face appearance of the plasma cells. And here is in the IHC how you will pick up these cells. Now the problem here is not doing the IHC, but what is the cutoff point? How many cells should there be in how much tissue to say, okay, the patient has chronic endometritis? And so there are various, methods or various cutoffs people have used. Either the whole tissue is taken, a part of the tissue is taken, but roughly what is said by Professor Simon said, if you have less than 5 plasma cells per high-power field in the tissue, then the influence on embryo implantation is unlikely. So perhaps the criteria that mostly is used is more than 5 plasma cells per high-power field. So that is also what I think our labs are using here. But so far the threshold, remains undefined. Now, you can, as I said, do a histology and look for the inflammatory markers. You can do microbial cultures. Again, limitation is how do you isolate the organism with the limited tissue or fluid that you have. But what is also coming into play is the metagenomic analysis. And you look at the genes and identify. But these are fairly expensive things to do in our setting and routinely for patients. So mainly we rely on the immunohistochemistry. How does it affect implantation? Well, there are, impairment of the endometrial receptivity. There is structural transformation. You have micropolyps, hyperemia, irregular or distorted anatomy. At a histological level, you will have leukocyte infiltration and infiltrate into the glands and vessels, which results again in structural disruption. Immune tolerance is altered. There's a gene expression which is altered. The genes which are involved in implantation process and immune tolerance, they are altered, and there is a alteration in the endometrial deciduization process. Also, it is believed that there is an effect on uterine contractility because of the inflammatory mediators, which increase the uterine contractility during the mid-luteal phase, and therefore affects the transuterine migration of the embryo. Now, it is believed that chronic endometritis may also interfere with fertilization and inhibit the transport of genes. So it is basically, again, the same basic concept. You have a higher, inflammatory markers and, less of the anti-inflammatory markers. So a balance, whenever that balance goes off, your implantation gets affected. Now, what is the prevalence? Higher incidence has been found in recurrent pregnancy loss, in recurrent implantation failure, and unexplained infertility compared to controls in this particular meta-analysis that was done. And what was found in RPL, it was about 30%, in RIF almost about 60%, and this was Cicinelli in 2022. But there's a wide variation when you look at reports. Some people report 3%, and some people also report 57%, and this is because of the different diagnostic criteria that people use, and perhaps even because of the different timing of biopsy that is used. Now, interestingly, this particular paper said that actually when you look at the fertile subjects, you find that there is no difference in the incidence of CE. Even in those patients, you will find 5%. How to finish it? So as I said, we do the genomics for it. The treatment is very simple: doxycycline, ciproflox, levoflox, or amoxicillin. Treatment results are very good. In GTB, we know we need 6 months of ATT. Now, we'll not go into this, but IUPRP has also been used where chronic endometritis has not settled with their regular routine antibiotics. Reproductive outcome, is compromised, as has been said in many of the papers, that you have higher RPL and lower implantation rates. But what I wanted to really bring about here is that should we routinely screen for this, because these are not simple, investigations, they cost money. So basically, we should look at those patients where there is recurrent implantation failure, or they've had treatment, recurrent pregnancy losses. Perhaps those are the patients where we should look at looking for chronic endometritis, because the cure rate is so fantastic. But not everybody believes this, and there is a SWOT analysis which suggests that we should not really, it is too early to make it a part of our routine infertility investigations, and it should be used only in RIF and RPL to improve the results. Now, in our own study at Mother and Child, we also, earlier we got very excited and we found about almost a 30% chronic endometritis rate in our RIF RPL patients and all. But when we looked at fertile donors, even there it was 33%. So at this point, we have to pick and choose the patients for whom we do the test, and the treatment is simple, so that's not a big deal at all. So with that, I'd like to thank you all very much, because we have run out of time. So basically, we should look for chronic endometritis when there is a reason to, and treat it, because the treatment is very simple and it would improve the pregnancy rates. Thank you very much.
Thank you, Dr. Nalini, and many questions about the screening for endometritis and tuberculosis especially, whether it is to be started on a preliminary basis when we suspect tuberculosis tuberculosis of endometrium? That is the main question that you can answer again in the
On the
chat
chat
box.
box.
The
But
pre-
just to say this, that we are working on bringing out algorithm or a guideline of how we should go about treatment of genital
Screening and
tuberculosis.
treatment, yeah.
Yes, and I think that should be very helpful. The only point that at this point, which I want to make is, if you're starting treatment, it should be full 6 months. Please do not give this 15 days, 3 months.
Yeah,
2 months treatment.
half-heartedly.
That should not be done. And, we know that sometimes we have to go on clinical basis. We are not getting anything else. So we do that, but the algorithm will soon be there, and perhaps it will help all of us to go a little in a more systematic manner. Thank you so much.
Thank you very much. Thank you very much.
Thank you. Thank you, Nalini ma'am. So our
Thank
next speaker is Dr. Sujata Kar.
Yeah.
Request to
I
chair
welcome
to
Dr.
kindly
Sujata
introduce
Kar.
her.
Yeah. Dr. Sujata Kar, we all know her very well. She's a best graduate and 7 gold medalist, golden girl, and created with the first IVF baby of the Eastern Orissa. So there are many publications at her credit. She's a reviewer, and welcome for this very important topic, that is recurrent implantation failure. Over to Dr. She had joined, and I asked her to share her screen. Yes.
I'm there. I'm sharing. I hope you can hear me.
She's there. I saw her. So
Hi.
she's talking
Can
on
you hear me?
recurrent implantation failure, a clinician's dilemma. Very important topic. Thank you.
Thank you. I hope you're able to hear me and see my screen.
Yes, both we can.
Please go ahead.
Thank you. Thank you. So I understand that it is a 15-minute talk, right?
Yes, it is a 15-minute talk.
Thank you so much. So I'll go quickly. First and foremost, thank you to ICOG for giving me an opportunity every time, and for Prateek, Seema, and Anu to remember and give me this opportunity every time that I'm there, although I'm not a part of ICOG at all. So my topic is recurrent implantation failure. Now, we will all agree that implantation is the last frontier for us to conquer as reproductive medicine practitioners. And we've come a long way in the last 40 years or 40 years plus, but still there are a lot of lacunae. The efficiency of IVF still remains low, with live birth rates ranging from 25 to 30% at a conservative and at a good estimate per started cycle, and the treatments are still very costly. And a recurrent implantation failure is a devastating reality for some patients of art who try multiple times yet are unable to get pregnant, even in spite of good quality embryos. And this is a real perplexing problem for the clinician. For the patients, it's a devastation because and for us also, because we are not able to supply them with any proper answers. So in my lecture today is divided into these parts. First is the definition of RIF, possible causes, what could be the possible risk factors, and investigation and therapeutic recommendations, which is based on 2021 guidelines. By definition, I think the most accepted definition now is failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen frozen cycles in a woman who is less than 40 years. And we know very well the difference between recurrent IVF failure and recurrent implantation failure. Failure to achieve pregnancy after several IVF attempts is IVF failure. And of course, the common causes are many: poor response to ovarian stimulation, poor embryo quality, increased maternal age, etc. But obviously, RIF is a subgroup of recurrent IVF failure. So recurrent, if you look at the current implantation rate, day 2, day 3 embryo implantation is around 25%. Day 5 to day 6 blastocysts are about 40%. And euploid blastocyst transfer, the implantation rate is thought to be around 60%, less than 60%. And RIF rate, recurrent implantation, is about 10%. So what are the causes? Clinically, what are the commonest causes that we find when we are investigating a couple of RIF? So I have just divided it into various categories. The first is related to the gamete or embryo factor, which is basically genetic factor, uterine factors, poorly understood factors, and of course, vast majority of unknown factors. In the gamete or embryo, oocyte quality, sperm quality, embryo quality or content, genetic content, paternal chromosomal abnormalities, in uterine congenital anomalies, acquired cavity defects, myomas, adenomyosis, hydrosalpinges, etc., endometriosis. Poorly understood factors are immunological factors, thrombophilias, previous endometrial trauma, impaired uterine blood flow, and of course, vast majority remain unknown factors. And we are also aware that classically it is known that the responsibility of reproductive failure lies almost probably 80% with the egg and about 10% with the sperm. The uterus probably only 10%. And unfortunately, the problem comes because patients have high expectation from art, and it is very difficult for us to explain to them that in spite of embryos which are looking good, why implantation does not take place. And this was a very nice paper, pretty recently published, and what became very popular and was very often quoted, the rate of true recurrent implantation failure. And this, they showed that those patients with the ability to make euploid blastocyst, less than 5% would fail to achieve a clinical pregnancy with 3 embryos transferred. So basically, it means that if you're transferring euploid embryos every time, and there is no obvious anatomical defect in the uterus, then the chances of an implantation failure is probably less than 5%. So these are the recommendations that I took recently from the Canadian Fertility Andrology Society Clinical Practice Guidelines. I have just put up 12 recommendations where there's a whole lot of investigations, possible therapeutic interventions that we can do for RIF patients. But it is really confusing what works, what doesn't work. What I have taken is just taken 12 recommendations, those who are most commonly used, and tried to give you some clarity on where we stand today, where evidence is concerned, whether we should be using them or not. Now, before talking about those, patient as clinicians and as a couple of RIF is in front of us, we must counsel them about 4 factors which are inherent risk factors for implantation. These are maternal age, BMI, smoking, and stress, for which we have no possible way of overcoming that. So one was, we know that the impact of age on embryo quality is very well understood, but on uterine receptivity, we thought that it does not reduce with age, but now evidence is showing, published literature, that yes, with age, even the implantation rate of the uterus or of the embryos reduces. With BMI also, we know that there are quite a few problems with class 1, class 2, class 3 obese women. They need higher doses of gonadotropins. They have fewer oocytes. They have lower implantation, and they have higher early pregnancy loss. But specifically for RIF patients, they must be aware that they have a slightly less chances of implantation compared to a normal BMI. Smoking, cigarette toxins might disrupt. There's a lot of science behind it. For lack of time, I will not be able to go into the details. But smoking and stress work at a level that can certainly have an impact on implantation. So investigative, and next is therapeutic. These are the usual things that we do when we face such a patient. Investigative, we have the hysteroscopy, thrombophilia, karyotyping, chronic endometritis, DNA fragmentation, immunological tests, various immunological tests, and blood flow studies. So let us go one by one and see what the recommendation tells us. Now we know that the hysteroscopy for cavity assessment. So usually hysteroscopy is not recommended in a patient who has normal baseline ultrasound before doing an IVF. But following a very good study, which was Trophy trial, it has also been found that it is likely that it will not be useful in RIF patient, and the evidence does not support it. However, in this subgroup of patients of RIF, we might be justified in doing a hysteroscopy to try and detect and correct factors which are not usually may not be visible on a regular transvaginal sonography. The best example is a chronic endometritis and maybe many others. Thrombophilia testing is not recommended. The evidence is pretty strong and there is very low or no evidence that thrombophilia testing is going to help us. Serological or endometrial immune testing in RIF patients should be limited to research setting, typically the uterine NK cells, LIF, autoantibodies. There are so many, and there is mushrooming of immunological clinics to manage. But there is strong evidence, although that the recommendation is strong, that if at all we want to do these tests for immune factors, they should be done under the purview of a clinical trial and not in a regular OPD or management setting. Karyotyping testing may be offered to couples with RIF, although the recommendation is weak because the evidence level is low, but it is recommended. Sperm DFI testing should not be routinely offered in RIF patients. However, here I would like to speak about RIF. The justification is that we don't have too many studies available, but it is possible that the time will come gradually as and when we will be able to give support to the fact that DNA fragmentation may be useful. But now the evidence is more in favor of recurrent pregnancy loss for RIF patients. Screening for RIF, but again, these are the recommendations, but it is again, evidence is accumulating that it is possible that chronic endometritis may be having a role in recurrent implantation failure. The use of endometrial receptivity assays should be limited to research setting. This is a strong recommendation, and there is no recommendation on uterine blood flow tests. The problem, like I mentioned earlier, currently there is no evidence that endometrial receptivity assays improve clinical outcomes in RIF. And so there was a time when ERA and similar tests were being done by a number of people, but now that has come down because it has proven that ERA is not of much benefit, even if it is a and for chronic, the problem is that it may be a good test. It might probably in the future tell us more consensus on diagnostic criteria and management about infectious morbidity. So therapeutic strategy, time lapse. Let me quickly go through it because the time is lacking. Potential time lapse is a potential advantage for improving the selection of the embryo, but the evidence as of now does not justify the cost, and it has somehow not been approved that it is something which can be used to help improve your implantation. PGTA also, there is insufficient data to recommend for or against PGTA for recurrent implantation failure, because the justice studies are very few in number and small in respect with this. IMSI, there are no recommendations, and probably the future of embryo selection to improve implantation rates will come from genomics, time-lapse imaging, transcriptomics, proteomics, metabolomics, and enhanced embryo selection. Madam, apan jai panibe. Laser-assisted hatching is not recommended. Mandatory FET is also not recommended. Endometrial injury or endometrial scratch is not at all supported, and not even in a case of RIF. Empirical low weight molecular heparin can be given, but in a research setting. Aspirin also has found to be of not much use. Similarly, for intralipids, glucocorticoid, GCSF, there is strong recommendation that it cannot be used. So I think my time is also almost up, so I'll go quickly. I think my previous speaker had spoken about immunological factors. So I think I can quickly come to the most important slide, which is the conclusion slide, which means that for recurrent implantation failure, there are various things that we can plan and various tests that we can do. Maternal tests, you can divide it into anatomical, thrombophilias, genetic, immunological, infectious, or altered endometrial receptivity, interventions, salpingectomy, fibroid removal, polypectomy, endometrial growth removal, and for thrombophilia, PGS, karyotyping. And for immunological also, we have a couple of things like, whether it's stem cells or PRP or mononuclear cells, IVIG, GCSF, antibiotics for infections, endometrial injury, GCSF to improve endometrial receptivity, and a couple of other options like I just talked to you about, PGD, PGS, etc., etc. However, we still do not have a good, take home that, okay, this is how you are supposed to manage a patient of recurrent implantation failure. And the evidence is very, very gray as to what you can use and what you cannot use. So if as clinicians, we have to take one takeaway from all the available newer options, add-ons for IVF that are there, I think this statement is good, which says that for any new evidence-based procedure that offers a more than 10% increase in live birth rate with respect to routine IVF for less than 10% the cost of the round of an IVF, that can be seriously considered or discussed with the patient. Thanks so much.
Thank you so much, Dr. Sujata, for joining us at such a short notice, and it was a wonderful talk.
Thank you, ma'am. Thank all the speakers for this wonderful session.
Yeah, and there's a question, I'll quickly answer it. Uterine blood flow.
Yes, please.
Want to take up the question, Sujata ma'am?
No, I was just saying that, yeah, somebody asked about uterine blood flow. So yes, it includes the uterine artery blood flow, Doppler, as well as the endometrial blood flow. Whether you can even use 3D power Doppler, and so many studies are currently available, but there is no standardized recommendation as of now. Tacrolimus dose also, I think I've never used it, so I don't often remember the dose. But yes, it has been used in research setting to improve the implantation.
Thank you so much, Sujata ma'am.
It was a wonderful talk. That too on a very short notice. That's great. It was a wonderful talk.
With this, we move on to the third and the last session of the day, which is a panel discussion on unexplained infertility, case-based scenarios. And I take the honor to invite the moderators, Dr. Seema Pandey, ma'am. She's President, Azamgarh Obs and Gynae Society. She's Librarian, Indian Society, ISAR.
Bas, Shrutika.
And no, ma'am, let me add, she's the newly elected Secretary UPSR. Thank you, ma'am. Welcome, ma'am. And the co-moderator is Dr. Shruti. Dr. Shruti
Shrutika. Dr.
Shrutika
Thakkar.
Dr. Shrutika.
I'm here. I'm Dr. Shrutika Thakkar.
Great. Great. And we have Dr. Bharti Dhore Patil ma'am as the expert. She's the director, Shri Hope Smile Fertility Academy. And Vice President.
Dr. Archana
FOGSI.
Basair.
Yeah. Second. And Dr. Archana Basair, ma'am. May I have her CV? Dr. Archana Basair, ma'am. Yeah, she's consultant obs and gynae director at Akash Hospital in Indore, and her past positions have been chairperson, FOGSI Imaging Science Committee 2015 to 2017, organizing secretary ISAR 2016. Welcome, ma'am. And we have a wonderful panel. Dr. Vimlesh Sharma. She's a senior obstetrician gynecologist at Hapur, and she's running a FOGSI certified training center for infertility. Welcome, Dr. Vimlesh. Dr. Sangeeta ma'am, she's head of the department Obs and Gynae, BHU, and she's also president of Varanasi Obs and Gynae Society. Welcome, Dr. Sangeeta ma'am. Dr. Kalpana Singh, she's founder, joint secretary, Indian Fertility Society Bihar chapter, and she's professor and head department of reproductive medicine, IGIMS Patna. Welcome, Dr. Kalpana.
And she is my junior from IMS BHU.
Okay, okay. And we also have Dr. Arshi, ma'am. I just saw her joining in.
Dr. Arshi Iqbal, she is director Arshi Fertility Center Kota, and she is ex-VP ISAR Rajasthan chapter. Welcome, Arshi.
Welcome, Dr. Arshi ma'am. And Dr. Vidya Thobi ma'am has also agreed to join as a panelist, and we are very happy to have you as a panelist, ma'am, and such a pleasure. So welcome, Dr. Vidya Thobi ma'am, again.
Okay. Shrutika, are you sharing the screen?
Yeah, I'll share the screen. Just kindly allow me to share the screen, please.
Or should I do it?
I think is my screen visible now?
Yes.
Yeah.
Go full screen slides.
Yes, yes. Okay. So good evening, everyone. I think let's begin this wonderful panel discussion. I've been listening to the talks, and I think we are following after 3 great talks. So coming to unexplained infertility, it is kind of maybe like an extension or almost similar to RF. So I was glad that we are following Dr. Sujata Kar's talk, because so many of the conditions are overlapping here, although it is not the same. So coupled with real or unobservable defect, infertility which may be prolonged and permanent, that is the definition of unexplained infertility. And so although that term has kind of been, a lot of people say that it should be abandoned because this diagnosis is a diagnosis of exclusion. And it happens because of a lack of a specific test, or sometimes it is like a misdiagnosis. And the most frequent reasons for misdiagnosis are mild to moderate endometriosis, mild degrees of tubal fertility, premature ovarian failure, immunological causes, which are not easily detectable. So what do we really need? Do we need improved diagnostic accuracy using rare, expensive tests that probably will not eventually improve the prognosis, or we need to be prudent about management of testing and management of unexplained infertility? The purpose of our panel is to decide what is essential and what is not essential, because there are so many tests which are available, and not all tests will lead to actually treatment options. So as I mentioned earlier, unexplained infertility refers to the absence of cause for a couple's failure to achieve pregnancy after 12 months of treatment, 35 years or older. So let's begin our first case study. Sorry. Yeah, Mrs. XRY is a 32-year-old woman with regular menstrual cycles. Her husband has normal semen analysis and has been trying to conceive for 18 months without success. Initial investigations show normal ovulation and tubal patency. So the first question to the panelists is, what is the diagnosis? Is it unexplained infertility? Should we start any treatment? And how would you like to investigate this couple any further? And later on, what are the management options?
Shrutika,
Any one
just
of you can take the
Shrutika,
question.
in meanwhile, please check your connectivity. Your voice is crackling. Am I right? Yeah, please.
Yeah, am I audible?
Yes. But the screen is changed.
Yeah. The Yeah, the screen is gone because I was trying to see. Could you all hear me read the case?
So,
Yes. Yes.
Hello?
You can try keeping your video off. That might improve the audio quality.
Okay.
Let's start
So
answering
I
this
would,
question.
shall I answer?
Yeah,
Okay.
please.
Yeah, is it better? Better? Yeah, please do.
Yeah, please start answering. They got it.
Okay. Actually, initial investigation, male factor, probably semen analysis that was normal. And for female factor, we need to do ovarian reserve testing. I think there is no information available about the ovarian reserve. So AFC is a very good method that should be done, because many a times even younger patients have lesser ovarian reserve. So female BMI and ovarian reserve should be assessed mainly by ultrasound. Again, AMH is a very good method, and AFC and MH combined gives very good assessment of ovarian reserve. And then about the endometrium. So ultrasound transvaginal sonography is a very important method to assess endometrium, which should be done nearly 20th day. So that gives a good assessment of the endometrial thickness. And at the same time, we can do the Doppler studies also. So this is the gross thing. Then we must always evaluate the endocrinological component. Like
But
sometimes
Kalpana, I would
hypothyroidism.
like to stop you here. And did I hear that the best assessment of endometrium is on day 20th of the cycle?
Yeah.
But how?
Because here the endometrial thickness and Doppler progesterone effect, ovulation has happened or not, everything we can know. Whether she's ovulating,
If
then
I
we'll
am
see
not
the effect
wrong,
of
if I'm not wrong, Kalpana, uh, once this endometrium becomes secretory, the exact thickness and the color Doppler flow changes entirely. And
Yeah.
that does not give the clear-cut clue what do we want for implantation. So, according to me, if I have to do it once, that should be day 11, between day 11 to 13, late follicular phase. Panelists, your
So
other
here
panelists,
I
what
want
you-
to
Yes, I will also prefer on day 10 or day 11 when the size of the follicle and the endometrial thickness with blood flow. If both of it are correlated with each other, so it is a good sign. It means the patient is
synchronization.
not having the ovulatory dysfunction. Always will prefer 10th or 11th day.
Bringing your attention to the basics, let me just first ask whether the diagnosis of unexplained infertility is correct. And if it is correct, should we start treating this patient? See, this is a lady who has only tried on her own for 18 months. She has not previously done any kind of treatment. Would it be right to start the infertility evaluation completely? And what all the advanced testing?
Yes, ma'am. I want to add something in this. The list of the investigation before this, we should always have the local examination, the per speculum examination, and the total overall the patient examination from top to bottom. Because so many times all investigations are normal. When we see the per speculum examination, there is a simple thing like the cervical ectropion or the cervicitis or the vaginitis is there. And when we treat, after a long list of investigation, पूरी मोटी मोटी फाइल के साथ पेशेंट आता है और एक सिंपल कोर्स एंटीबायोटिक के बाद पेशेंट कंसीव कर जाता है. तो वी शुड नेवर फॉरगेट द बेसिक थिंग कि पर स्पेकुलम एग्जामिनेशन एंड ट्रीट अकॉर्डिंगली.
So
before
panelists,
starting any specific treatment.
Bilkul, absolutely right. But the thing is, as Dr. Shrutika said, this couple was trying for 18 months, but there was no investigation. So why are we just labeling them as unexplained infertility then?
No. We
And
will
she's
not label it.
Basically, this patient has not yet visited a consultant or an infertility place and not a detailed history. We don't know anything about her sexual history, whether they are, how frequent they are, what time they are doing. We don't know anything about their lifestyle. What exactly, this question is not complete because it does not narrate the BMI, it does not narrate whether the basic investigation has been done, her thyroid, her prolactin, the ABCD of the investigations have been done, whether she had already taken Zobologen or so many so forth. But the thing is a detailed history first, then the basic examination, then the transvaginal PV is must, and then a basic transvaginal scan maybe on day 2 or day 12, 13 for endometrial thickness is the starting point. And in unexplained infertility cannot be labeled on this patient because we have not even started working on this patient.
Yes, absolutely right.
So suppose everything was fine and
I was
she had
looking for that we cannot call this. Yeah.
please continue.
Is probably cannot be labeled as unexplained infertility because that is a diagnosis of exclusion. And like the panelists have rightly said, there are so many infertility evaluations like ovarian reserve testing that were not performed correctly or not done at all in this case. So we need to re-emphasize that this is probably it might emerge as unexplained infertility, but at present we don't have the diagnosis. Coming back to when to start treatment, there are guidelines as to when to start treatment in the case of unexplained infertility. Either the duration of trying time should be more than 2 years or the female partner has to be more than 35 years. That is when treatment is generally indicated and the prognosis gets worse with higher female age. But with regards to the Indian setup, do you think that 35 years is the right cutoff for Indians? Can any of the panelists take that? Because this is the international definition for unexplained infertility, that you start investigations and treatment when
basically
if it is less than 2 years.
Basically, in Indian society, Indian females are lagging behind. This all data is for European females where the fertility is optimum till 50 years as compared to Indian female. Here, the AMH and the ovarian reserve are going declining at a very high, fast rate. So definitely this parameter cannot be taken as 35 years baseline to start workup. It should be as early as possible, maybe 30 years, yeah. You should start thinking about it.
Okay, so Dr. Kalpana, in this particular patient or in general in all these females, do you do AMH regularly to make the diagnosis of unexplained
Usually,
infertility?
yeah.
Is AMH required?
Yeah. First of all, most important ovarian reserve marker is age, and then routinely we do AFC on second day of menstrual cycle, along with ovarian volume and stromal blood flow. That gives us a good assessment, and it has got a good sensitivity and specificity as well. But we do AMH just to increase the sensitivity and specificity so that we have a good idea about we can prognosticate the patient better about the response. So we do, but AFC also is very good marker for ovarian reserve.
Okay.
Along with ovarian volume.
Agreed. As AFC has inter-observer variation, AMH almost remains fixed throughout the cycle, very lesser, though you should be doing, if you are doing, you should be doing it on day 2 or 3 of the menses. But even if you do it on day 20 or day 23, there will not be much difference. Or patient is on OC pills, there is some degree of suppression, or patient had taken chemotherapy in recent past or radiotherapy. So AMH gives you a good value and it gives you time frame that what kind of treatment you are planning for this particular couple. So, Dr. Vimlesh, now we have decided that male factor was almost normal. She had an AMH of 1.9 nanogram per ml. AFC 4, 5, and 5, 6, right and left side. And now we want to know HSG bilateral patent tubes. Now, our question is whether you will start giving her some treatment at this stage, and if yes, what will be your first line of treatment for this particular patient? And how will you counsel?
It depends upon the age of the patient. As we have,
she is 32 years.
what's the age of the patient, ma'am?
32 years.
32. So in Indian scenario, towards the higher side, so I want to induce her actively and without wasting that time. Initially, I will prefer to give the oral ovulation and monitor the folliculogenesis. If it is corresponding accordingly, it's okay. Otherwise, we'll add the gonadotropin in the same cycle. I will not waste the time. If already
So
18 months had
you will
passed.
be doing ovulation induction with time
Yes.
intercourse.
Yes, and I will explain the prognosis. If she will conceive within 2 or 3 cycle, it's okay. Otherwise, I will prefer to do the IUI in the same patient.
But this patient is
In the
I would like
successive,
to,
matlab, in the future,
this
it
particular
will be the
patient
future plan
is
if it's
ovulatory.
she doesn't conceive.
Dr. Kalpana, what is your
yeah,
opinion?
actually, I want to say
Apart
that
from where
whenever
she left,
ovulation induction is done or ovarian stimulation is done for IUI, it should be combined with gonadotropins and IUI, because this has got better pregnancy rate, better positivity rate, and IUI alone, ovarian stimulation alone has got 3 to 4%. So if we are stimulating, if we are enhancing the ovarian aging, it should always be combined with IUI. We should not leave the patient as such after stimulation.
in unexplained infertility, there is no provided we are taking unexplained infertility as an ovulatory patient. There is no role of simple ovulation stimulation or super ovulation if you are not combining it with intrauterine insemination. So, Dr. Arshi, what will be your plan and how will you counsel this patient? First of all, her AMH is 1.9 nanogram. She is 32 years old and she's been trying for last 18 months. And
So
how will
we are
you
not,
proceed?
and we are not taking her as an unexplained infertility patient right now. We have not labeled her.
She is unexplained infertility
Okay.
now.
Okay. So first of all, we need to investigate or we need to counsel the patient regarding lifestyle modification, first of all, because nowadays stress factor and so many factors are there, weight and all. So that all side by side should be managed. And we should counsel her that your count is this and this, matlab 5 and 6. So we need to work up in a way that we will try for 3 cycles of IUI, mostly 3, not more than that. And if she does not conceive in those 3 cycles, maybe we can think for IVF in further cycle, because her AMH is an average AMH. And IUI definitely yes, but only 3 cycles, not more than that. And if everything is fine.
And Dr. Shrutika, are you there? So these are the evidences. So if, as Dr. Kalpana has told that if you are going for IUI, you should be not taking only letrozole or oral ovulation. You should be combining it with gonadotropin to get the better result. But as per the guidelines, first line of treatment for unexplained infertility is oral ovulation plus IUI as per the age and counseling of the patient, whatever if she has decided to go for IUI. Am I right?
My
Yes.
screen now available. Okay, is it seen?
Yes.
I have shared
Yes.
or you have shared. I thought you are not able to, so I did.
Okay. Fine.
So yeah, please go ahead, Shrutika.
Yeah, so coming to the, can we move the slides a little?
Back or forward?
Yeah, so no, this is okay. So this is the slide that I wanted to show, that female partner age is also very, very important. All of you all mentioned ovarian reserve testing, the back slide. Female partner age, somebody mentioned about history taking. So maternal age, maternal menopause age is also predictor
Ritika, we are not able to hear you clearly, not at
time that the ovarian response will start declining. So if we take a good history, like for example, it starts declining, that is because of the early age of menopause that is there in our country. So this is also something that we can look into in the history. Go on to the next slide. Dr. Seema, am I audible now?
Yeah, but your voice is crackling when you are speaking. For the audience benefit, I wanted to say, since the Indian women, they get their menopause by 47 to 49 years, the acceleration of decline of fertility takes place 12 to 13 years before that. So in our country, a woman of 32 years, she has already lost almost 70-80% of her fertility potential. So she has to be counseled about this time frame, that she doesn't have time to waste, and at least the treatment which should be started one natural cycle followed by intrauterine insemination, as Dr. Arshi said, for 3 cycles. If that fails, couples should be clearly guided towards the in vitro fertilization, because the chances of her getting pregnant would be better with that. So I think all of us are on the same page for this patient. We are going to do 3 cycles of IUI followed by IVF. Any difference of opinion? Okay. My favorite question is, do you label, when will you do the IUI? Do you believe in doing diagnostic laparoscopy, as Dr. Shrutika in the beginning said, that unexplained is not always unexplained? It is because we are not able to see those things, we are not able to diagnose. So do you label a patient of unexplained infertility and take her for IUI before doing a laparoscopy, or do you believe in doing diagnostic laparoscopy for these kind of patients? I'll start from Dr. Vimlesh. One line answer, yes or no?
Dr. Seema, I will prefer to do the histolaparoscopy before labeling the unexplained infertility and before going forward for IUI or IVF.
Okay. Dr. Kalpana?
Yeah, endometrial cavity evaluation is recommended in cases of when patient
What
is
do
not
you do?
conceived.
What do you do?
After 3 IUI failure, as a protocol, we evaluate the patient by doing laparoscopy, especially hysteroscopy and laparoscopy if indicated.
Okay. Dr. Arshi?
I will be doing HSG first initially
So
before
that is
starting my
done. That is done.
That is done. And if is not having any problem, then I'll go with 3 IUIs. And if still she does not continue conceive, then definitely laparoscopy is a must.
So
Because I do not believe anything is unexplained. If you put the scope, you definitely find the problem.
in 40% of cases, we find mild to moderate endometriosis, some degree of adhesion, chronic endometritis. But looking at the cost effectiveness and invasiveness of laparoscopy, first line of treatment is IOI. If it taking tubal factor, semen, and ovulation, they are in place. First line should people do is IOI, and then they go for according to the ovarian reserve and couples wishes for either for diagnostic laparoscopy or IVF, because this patient is at borderline. She can go for both. That depends on our counseling and how are we taking other things. Otherwise, laparoscopy has there is not much role of diagnostic lapro and hysteroscopy in this era, when we've got excellent 3D ultrasounds and our transvaginal probe has become our third eye. So,
Dr. Seema, so many times we get the peritubal adhesions, and
definitely, I
the
agree.
follicular receptivity is so low. And when we did the histolaparoscopy, and surprisingly, patient conceived in the next 1 or 2 cycle.
That is 5 to 8% of
We always
patients of
prefer, because
unexplained
it is a
infertility.
comparatively cost effective, and the giving treatment for 3 cycle of IUI and then go for the IVF, better to do the histolaparoscopy.
Agreed, Dr.
But
Vimlesh. As I told
unfortunately,
you, Dr. Vidya, yes.
the No, this is Dr.
Shrutika,
Shrutika Thakkar. Yeah. No. So unfortunately, the guidelines don't agree that we should go for hysterolaparoscopy so early in these cases.
Because of invasiveness and cost
Yes.
effectivity is more with IUI than laparoscopy.
Then with laparoscopy, yes.
So next question, we'll finish this here. Most of our panelists, they have agreed to go with oral ovulation plus gonadotropin. Any of you will go for pure gonadotropin IUI cycle?
Not initially.
Okay. So what's the reason?
It's again a question of cost effectiveness, ma'am.
So
We'll
supposing
add the ovulation
And
with the
this
gonadotropin.
patient is not having ovulatory problems, so ovulation stimulation, ovarian stimulation with gonadotropin with IUI, preferably letrozole plus gonadotropin, will give a pretty good pregnancy rate in 3 cycles. So that will be most cost-effective treatment.
So any of the panelists have any plan of action for this patient? How many cycles with letrozole or clomiphene, and then you will move on to say gonadotropins? Can anybody elaborate a little on that?
Basically going with letrozole and 1 to 2 gonadotropin maybe in third cycle, not
In
in
the third
first
cycle.
itself.
Yeah.
Yeah.
So that is what we wanted to know, that what is going to be the ovulation induction choice of agent. And yes, we need to know here that when there is letrozole only cycles, the success rate with IUI is around 22%. Whereas when we do a gonadotropin cycle, the success rate increases to around 35%. So the plan of action, like Dr. Arshi said, is very clear that after say 2 cycles of clomiphene, considering that she's 32, then maybe we should move on to gonadotropin. And if you have decided, what would be the starting dose, Dr. Arshi? For gonadotropins?
Basically, no, it will be low dose only. Maybe 150 will be okay, because
At
here
32
I don't
years?
know her weight or nothing is told. Only I know the enteral count, which is 4 and 6. So 150. Yeah.
Yeah. So in IUI, most of the time we are going with fixed kind of dose, 75, 150 to begin with, isn't it? If we
Yeah.
are mixing it.
And Dr. Seema, we got very good result with the protocol of Dr. B.N. Chakravarti. What he used to give on second day, he used to give this 1 dose of the gonadotropin, that is the 75 milligram of the HMG, and then give the clomiphene that time. Now we are giving the letrozole, and on 8th day again we give the second dose of the HMG. In that case, we got comparatively good result in the low cost.
Okay, Dr. Arshi, you finish this, then I'll tell.
So normally we do induction on day 3 with the letrozole, and in few cases we give gonadotropin 150 on day 3, and day 5 we always add it with letrozole and do follicular monitoring from day 9 of the cycle. And if everything is fine, as this patient does not have any hormonal, we are not told about any hormonal ovulation problems, so definitely the eggs will be good and follicular monitoring. And after this, we can give a trigger 5000 HCG and 36, according to your convenience, 36 to 40 hours, we'll do single IUI.
So, Dr. Vimlesh, the reason Dr. Chakravarti might have been using that protocol was along with cost effectiveness, he was trying to increase the threshold by adding one gonadotropin with first day of clomiphene, and the 8th day one, it was very smart move, and on 8th day it was just to extend the window so that follicle could grow better. And as per Richard Ligro, earlier it was said that IUI with choice of ovulation for unexplained infertility should be this thing, clomiphene citrate, and for PCOS it should be letrozole. But recent studies have shown that they almost have similar kind of result, and not chances of multiple pregnancies are lesser with letrozole, which we are more concerned about in our IUI cycle, not OHSS. So, and letrozole decreases the requirement of gonadotropin theoretically. So, a combination of letrozole and gonadotropin could go hand in hand, and could give better results than clomiphene plus gonadotropin, but it doesn't imply that you cannot use clomiphene. The only reason we do not prefer it is its endometrial anti-action on that part.
And yes, Sujit.
There is the question from the audience. Somebody has asked whether any medication should be given to the male partner. What is mentioned
Very
in
good
the
question.
question is that the male semen parameters are normal. And would you still want to medicate the male partner in unexplained infertility?
No,
Dr. Arshi?
no, not at
Yeah,
all.
exactly.
So
That is
many,
what the guidelines say.
so many time, madam, when the AI has come, we got ki morphologically semen parameter is very abnormal. So in that case, or ye sperm fragmentation test, so we always give the doxycycline course of 10 days before doing the IUI, and we
So
got
this,
very good
the
results.
whole need for this panel is that only that this is unexplained infertility. Patient has tried
Empirical.
for only 18 months. Could we do sperm DNA fragmentation at this earlier stage? That is what we need to establish here, and for the benefit of the audience, that these are tests which are very expensive and to be done later on in the couple journey,
And
not at
second,
present.
and
DNA
second,
fragmentation, yeah.
and second thing, that when you are doing your semen analysis, you can look at your number of pus cells, and that can also give you an indication. The reason of this panel is that we do not do what is not beneficial. It could benefit one person, but something which is not to be recommended for each and every case. Giving antibiotic should not be recommended to each and every couple who is undergoing IUI, male partner or female partner, until unless we are having some kind of evidence of pelvic inflammatory disease or some kind of difficulty in sexual intercourse, burning, and all those findings. It shouldn't be
Yes.
used on regular basis because you will make this patient antibiotic resistant.
So I think we've had enough discussion
So
on this
moving
case, Dr.
to,
Seema. Moving on to the second case.
yeah. So main difficult, yeah. I'm trying to, yeah, this is the one.
Yes. So Mrs. GSK is 29-year-old, married since 5 years. She has done 5 follicular monitoring cycles at various good clinics in the town. 4 were clomiphene citrate letrozole cycles, 2 with IUI. A rupture has been documented well. ET is 6 to 7 millimeters in the follicular charts. 1 recombinant FSH cycle and HMG cycle has been done, in which IUI was also done. Semen analysis normal 20 million per ml. Good motile sperms. Tubes are patent. UAG pelvis is normal. AMH is 2 for this patient. TSH prolactin that you guys were asking is normal. She has been advised IVF by the previous center. And now she has come to you, hoping that you will do something else. Patient is saying, or IUI कर सकते हैं क्या आप? This is a very common scenario that we get in our clinics. Somebody else has advised IVF, patient has now come to you. What will you do next? Dr. Kalpana, the question is to you.
Actually, I was just reading the question. So she has undergone 5 ovarian stimulation cycles.
Yes.
And IUI was done in
4 times.
4 times.
Yeah.
And patient is young, her ovarian reserve is good.
It's 2. AMH is 2.
AMH is 2.
Yes.
Yeah, up to maximum of 6 cycles can be attempted. Beyond that, we don't go. So because here IUI was not done in all the ovarian stimulation cycles. So if we can do endoscopic evaluation, or you can do a detailed transvaginal sonography or cyst, so that we rule out why she is not conceiving. And then, of course, we can go for 1 or 2 more cycles of IUI using gonadotrophins also, and with proper monitoring and everything.
This is very
Anybody
important
else?
in this case.
The
Yeah.
important thing, what I am seeing, endometrial thickness. Endometrial thickness is 6 to 7 millimeter in spite of good ovulation. So it
Yes.
means that there is a local cause, might be the endometritis, chronic endometritis or acute, anything is there. So first, we see the endometrial thickness के साथ साथ हमें blood flow और देखना है. If there is a good blood flow with the 7 millimeter of endometrium, it means कि everything is okay. If there is no blood flow, it means कि it's a case of the endometritis. So we should first exclude the local cause. Do the hysteroscopy.
Yes,
So
here
in
I
this
think most of
case-
you all were answering in the previous case about hysterolaparoscopy, and probably this is the case where here after 3 failed or 4 failed IUIs, maybe checking for endometriosis and endometritis in our country setup may give us some benefit. So
It
what
depends,
exactly
Cox.
are we trying? Yeah, can somebody tell us a little more?
We-
What exactly are we
we
trying to
don't-
look out?
Yeah.
Yeah,
Already 2
in
cycles.
hysteroscopy, actually chronic endometritis is very common, and many a times we are not able to diagnose. So in hysteroscopy, we can know about it, and laparoscopy should always be combined. So tubal, peritubal adhesions, tubal motility, and like mild cases of endometriosis, all this can be diagnosed. So after 3 IUI failure, the tubal factor, peritoneal factor, and endometrial factor should always be addressed.
And what about
will
anatomical
add the
factors?
endometrial
Sometimes there are
factor.
polyps. So
T-shaped uterus.
Yes, we'll add the endometrial for for PCR or for the AFB culture to exclude the chronic endometritis, tubercular
Also,
endometritis.
how many of you will want to do a lateral metroplasty here for 6 to 7 millimeter lining in case you see a mild T-shaped uterus? The HSG report has said that everything is normal. But when you do a hysteroscopy, would you want to do a lateral metroplasty here?
If we are
If there
getting the
is
good
T-shaped-
endometrial cavity, so we'll not do. If the endometrial cavity is not satisfactory, we'll do. Matlab we are
if
doing
there is
the lateral
T-shaped
metroplasty.
endometrial cavity,
If the
then
cavity is not
we'll go for
satisfactory.
lateral metroplasty, otherwise not.
Yeah, because the lining, so generally lateral metroplasty is indicated in T-shaped uterus only when the endometrium is thin. So here, as the patient has a thin endometrium, maybe correcting those anatomical sub-factors will be
My question
beneficial
is,
for
how
us.
often you are finding T-shaped uterus? Is it very common?
It should not be
My
very
question
common.
Yeah, T-shaped uterus is common in cases of adenomyosis also, because of
But
endometriosis
it is
also,
not
and COX is also
it is
important
rare at
cause.
times.
DS
Okay,
exposure is not
girls.
common, but these cases are nowadays increasing because of adenomyosis, endometriosis, and COX also.
Yeah, and now this patient's husband can undergo DNA fragmentation tests. So now we are moving, actually, ghanti baj gayi hai, so we'll move fast.
I think endometrial evaluation, we can talk a little bit more about what all tests are there for thin endometrial evaluation. Can anybody of you take the question? What all will you do? What are the recommended tests for tuberculosis that you would be wanting to perform? Can you do microbiome profiling here? And could this patient be a case of chronic endometritis?
Definitely, initially we'll monitor her for 1 cycle, and after seeing whether she is improving or not, we can even add estrogen to see whether it is responding or not, the endometrium. And if it is not, then by the time we can also get a TB gold test done and see the blood parameter better, is it coming positive or not. And by the time we do laparoscopy, definitely biopsies can be taken and sent for histopathology and culture.
Dr.
TB
Ashish,
gold
TB
test
gold
is not recommended nowadays.
not
It is
recommended,
banned.
yes.
Only CB-NAT can be done, and that too in premenstrual phase. Most of the time we are doing hysteroscopy in postmenstrual phase. So the timing is not correct. We have to take the patient premenstrually or during the first day of menstruation only for take the endometrium and then send it for CB-NAT
So
or
gene
expert.
expert and TB culture would be one thing if you are suspecting tuberculosis.
Which never comes
That is
positive.
something. Yeah, it is
Yeah,
rarely
it
positive,
never
but you
comes.
can.
Whoever
Yes.
comes positive with laparoscope showing full COX ka picture, GNAT and gene expert is always negative.
The visual picture is more important while doing laparoscopy. You find many findings, adhesions,
So
granulomas.
very quick, yeah, but time is up, guys. please. So which test can be performed for microbiome profiling? And how to treat chronic endometritis? These two questions you guys take.
Microbiome profiling we are not doing, and based on
Chronic
this thing,
endometritis, are you doing
treatment treatment is
CD138 cells
doxycycline metronidazole for 14 days.
and CD138 cells koi kar raha hai? Any one of you?
No.
That is easily
No.
available now.
Yes,
If you're
these are easily available. You can do
if you're
RT-PCR for
suspecting- simultaneously you can send both. Your histopathology specimen can, in that specimen, CD138 can be done.
is easily done, and you can also do a RT-PCR for common chronic endometritis bacteria like Staph aureus, all that Neisseria, chlamydia, which we generally don't pick up. So you can do a complete DICE test, detection of infectious chronic endometritis panel is available along with CD138. It is very beneficial to have targeted therapy rather than just empirically giving doxycycline.
Yeah. And as per the species, you can choose your antibiotics. And
Yes.
majority of time, since doxycycline is a broad spectrum, that is first choice. Second choice is quinolone, ciprofloxacin, and amoxiclav as per the these
Bacteria.
specific bacterias. Okay.
Can
So
we take the third study, or we should?
I think time is up. Nilima, Shreya, who is there?
Yes, ma'am. Time is up actually.
Okay, so we will just, who will summarize this case? I'll stop sharing. Regarding the evaluation of a patient who has undergone 5 IUI cycle, and she had come to you for further treatment, and she wants to know whether she can undergo for IUI again or not. What will you do? Whatever we have discussed, just summarize it in 2 lines, and then we'll say thank you to our esteemed panelists.
So we will be doing the counseling and taking her for hysterolaparoscopy, and during hysterolaparoscopy, as per the findings, we'll be taking samples or we'll be doing evaluating the patient, and then main emphasis should be done on whether she's having genital COGS or not. That is important. We need to even see the subhepatic region because it might be because of PID and all, and find the main cause of the disease and treat accordingly if required. Basically, ATT can be started if evidence is there, and most of the time patient respond and they conceive by themselves, most of the time even without IUI. This particular patient, because husband was okay.
Anyone wants to add anything?
If at
Any
all
last-
ovarian stimulation is being done, so it should always be combined with IUI, because many times in periphery people just keep on stimulating the patient, and ovarian reserve drops dramatically, and then patient comes to us with a very poor ovarian reserve. So I would like to say that whenever stimulation is done, it should not be wasted, should be combined at least with IUI, preferably along with gonadotropins. It should be done.
Very good take-home messages.
Yes.
And
So guys,
before
first
giving the trigger, always correlate the follicular size and the endometrial thickness with the blood flow. If there is a perifollicular blood flow and the endometrial blood flow is good, it means कि implantation के लिए endometrium ready है, then only we should give the trigger. क्योंकि यदि timely trigger नहीं दिया गया है before doing the IUI, then also the failure of IUI is there.
Students, you keep filling your form. I just want to summarize that before blaming the neighborhood doctor, start looking at the problems of this patient. Take it a stepwise, systematic way for male and female, both the partners. And if you find out any kind of disease or any abnormality, try to treat it first and then tell her about the next mode of treatment. And that would be the best approach for these kind of couples who keep coming to us. Thank you so much to my dear co-moderator who did all the work, and I was just sitting here in Japan.
No.
Thank you so much, Shrutika, and thank you, my esteemed panelists. डॉक्टर विमलेश दी, मैं बात भी नहीं कर पाई थी, डॉक्टर कल्पना, डॉक्टर अर्शी, आई कॉल्ड हर जस्ट लास्ट मिनट. Thank you so much. It was a very good discussion. So, students, have you done your this thing? Your post-test quiz? Have you filled the form?
Shreya and Nilima will post the link now after
Yes,
the
yes, sir.
It was in the. She said ki she'll put it in the chat box. Okay.
This is the QR code as well. You can directly scan this. You have difficulty in clicking the link. And you have exactly 10 minutes to finish this. Once your 10 minutes are up, we will have closing remarks.
Okay. Thank you, Simadi, for the opportunity. It was nice interacting and being the panelist. So
Thank
I
And
enjoyed it
meanwhile,
thoroughly. Thank you very much.
my panelists and co-moderator, if there are questions in chat box, please keep answering so that there are multiple questions. I can see
Yeah.
53 or 63 notifications. So please do that.
Thank you, Dr. Seema and Dr. Pratik and whole team of ICOG for this wonderful opportunity for having this panel discussion.
We have been requested to keep quiet by the candidates because they need to focus and finish 20 questions in 10 minutes. At the end of that, Seema and the coordinators will give out the correct answer.
If link is not opening, just scan the QR code.